We are live now.
Yeah. Very good afternoon to one and all of you here in this ARC webinar on video bouquet of cataract challenges. And I promise you that the next 3 hours is going to be so gripping, like a roller coaster ride, but again with lots of learning, because we have the best of you amidst us and the best of expert panel who are going to guide us along. So we have with us on the expert panel, Dr. Ramurthy, who's the chairman of the Eye Foundation Group of Hospitals and also the past president of AIOS. And
louder, Chitra, not able to hear you.
Not able to. I didn't know you're getting old this fast. I'm so loud. Can you hear me now?
Yes.
So we have with us Dr. Ramurthy, who's the chairman of the Eye Foundation Group of Hospitals and also the past president of AIOS. And I'm sure he's going to have his teaching pearls one after the other lined up for us. Joining us shortly maybe would be Dr. Partha Vishwas, who's again the director of the Trinetralaya Hospital of Kolkata, and of course the very effective chairman scientific committee of our AIOS. And we look forward to a great AIOS in June under his guidance. Joining us soon is Dr. Namrata Sharma, who is a professor of ophthalmology of the Cornea, Cataract and Refractive Surgery Services, and also our honorary secretary AIOS. And we all know so distinctly that she has been an amazing woman in her tenure in these very difficult times. With us again is Dr. Mohan Rajan, who just needs no introduction. He is the chairman and the medical director of the Rajan Eye Care Hospitals, and also a very effective president of our Tamil Nadu Ophthalmic Association, who has brought in a great change in this last 1 year and made it an amazing series of programs. With us again is another very popular individual, Dr. Kapil Bora, who is the medical director and founder of the Kapil Eye Hospital, Ambala, and an amazing versatile surgeon, and just the person we need to comment on all those interesting videos we are going to have in the next 3 hours. And last but not the least, we have with us Dr. Rohit Om Prakash, again a very national and international figure who heads the Om Prakash Eye Institute at Amritsar, and and he would have huge amount of teaching information to pass on to us in the next 3 hours as he goes through all those interesting videos. Co-moderating with me is Dr. Satyajit Sinha, who is the medical director of the ABI Hospital at Patna, and he is the medical member ARC East for the 2nd term and a very popular figure at the national level. So without wasting time, let's go on to our first speaker, Dr. Sudipta.
Ma'am, I'll have to
Oh yes. Before we start, let's have a look at the very interesting video to be played by the Entode. After this amazing video of Entode, we shall now go on to our first speaker, Dr. Sudipta Mitra, who's a senior consultant at Amri Hospitals, Kolkata, a very popular person from her hometown, and a great friend of many of us, and again, a very prolific surgeon. So let's have a look at a video and get to rig her with her questions and doubts.
Thank you, ma'am. It's a pleasure being here. Good afternoon, everybody. And I thank Chitra ma'am for giving me this opportunity to present in this.
I think, Sudipta, maybe you could switch off your video so that your connectivity error problem is there. We switch off your video, maybe we could hear your voice. We can't hear you. You're muted. Sudipta, you need to unmute yourself. You have to unmute yourself. We can't hear you. Just a minute. Dr. Anand, she's not able to unmute herself.
I've tried unmuting her, ma'am. I've sent the request, but still she's muted. I put that also, you can see.
Yeah.
Microsoft microphone is disabled.
Oh, okay. Sudipta, maybe
Shall
Dr.
I share
Anand,
the presentation?
Speaker, Chitra,
yes.
go on to the second one and then come back to Sudipta.
Sir, we can share ma'am's presentation now. I can do it at my end.
Yeah.
If Dr. Chitra will allow me.
Yeah. Yes. Dr. Anand would play your video, Sudipta, and you could talk along. There's some network issue at your end. Maybe you should switch off your video too, and so that we can hear your voice. She has actually a good video to show. So can you? Just 1 minute. Could you stop playing? We are not able to hear Sudipta.
Ma'am, Dr. Sudipta, please unmute yourself.
She's unmuted.
Yeah. Her audio is coming but distorted.
Oh.
We can follow Dr. Mohan's suggestion, go to the second speaker.
Yeah, we'll go to the second speaker, Chitra, and come back.
Yes, yes.
Dr. Sudipta, I would advise you to disconnect, restart your computer, and then again connect. Looks like you have a network problem.
Hello.
It's
Yes,
better
ma'am.
now.
Hello.
Yes,
Yeah,
can you
but-
talk now?
Yes.
So
Yes.
run
Yes, ma'am.
So
I can
run the
hear.
video from the beginning.
Yeah, please
Dr. Anand.
start. Please start.
Yeah, okay, start now.
Yeah, yes, ma'am. No issues. Thank you so much, ma'am. I'm very sorry. For the evening, afternoon is intraoperative floppy Irish, which we usually see as a variant of small pupil syndrome. And here, not only the Irish,
Sorry, Dr. Sudipta. Please switch off your video. We can't hear
Yes.
you. Dr. Anand, can you stop her video? Dr. Sudipta, please switch off your video. Yes. Now I think let's hear you because there is a huge network problem at your end. And now,
I'm going to start the video from
Yes.
where it is right now. A little
yes. And continue from here, Dr. Sudipta.
Dr. Sudipta, I hope you can hear us and you can speak.
Okay.
Also.
In
Can you speak a few lines? I have a doubt on the network. Ma'am.
it's
Just speak
intraoperative floppy Irish syndrome is a variant of the small pupil, and it is observed during cataract surgery in some patients currently on treatment on tamsulosin. And this was first described by Cheng et al. I'm going to describe a patient who is 72 years old, hypermetropic, with multiple systemic disorders, had a very good dilatation of the pupil, and we were not expecting an even full surgery. IOP was normal. So going with the routine steps of staining the anterior capsule with blue dye, I went on pushing in air and blue dye, but very soon I noticed pupil was going down as I tried to take out the dye and push in a bit of viscoelastics. And in these patients, it is very unpredictable if it would react, because the other eye was an uneventful surgery. So I tried to put in a bit of more viscoelastics, and I could see the pupil peeking towards the entry wound, and very soon I could see the pupil there out. Now I did not make any other incision, tried to reposit it back, but my pupil had already gone down. I took out the extra bit of viscoelastics thinking I might have pushed in more, tried to reposit it back, and at this point I had to take a decision what to do. My pupil was going down. So I thought, let me try from the main wound, put in some adrenaline to dilate the pupil, but it was not helpful. So I went in through the main wound thinking there might be some viscodilatation and then I could do my rexis. So I made a 2.2 incision through the main wound, used my keratome for it. The eye was soft, fortunately, so I put in a high density viscoelastic initially so that I could stabilize the anterior chamber, but nothing would help me. The iris was a bit floppy, so it came out through the main wound again, and now it was real trouble for me. And now I had to really take a call what to do. Usually we do not try to reposit the iris from the main wound. This was a mistake because usually it will go down more and no more. But in that fit of time, I did it. I loosened up the speculum, thinking that might have created extra bit of pressure. Did a bit of massage, thinking that might have created fluid misdirection, but nothing was really helpful. I was soft, so my target was now to do a good mydriasis and prevent the pupil from coming out. So this was intraoperative floppy iris. Now I reposited the iris from the side port, and then I went on. The AC was very shallow and still it was unstable. I could manage a rhexis somehow, but since the dilatation by this time was somehow okay with visco, with adrenaline, but in phaco there was a big problem as I was catching hold of the iris now and then, traumatizing the iris because it was flaccid. So with my chopper, I was traumatizing it. So I used high density viscoelastics and then had to choose for between a pupil expander, what type I would use. I usually prefer to do with hooks in these cases because it not only keeps my pupil expanded but keeps the iris taut because the iris has become flaccid. I used 4 hooks. I sometimes use 5, but here I used 4 hooks. And a very important point is until you put the hooks diagonally opposite, you should not give your pull because it has to be optimum. Otherwise, since the iris is flaccid, later on it may end into a tonic iris. I used a repositor to glide my phaco probe so it does not injure the iris. Furthermore, we can use a fifth hook there instead. So the video has paused. Hello.
Yes, yes.
Hello.
And the video is still
So
this
the
much
video
only.
has paused.
4 minutes
Please start.
video, it's over, ma'am. It was a 4-minute video.
No, sir.
Ma'am, it's ended.
So
If you
because
see-
we lost time in the beginning.
Okay, I can again start if you want, but the video duration was 4 minutes, ma'am, and it has automatically stopped. It's end if you see.
See, there it is. That is, thank you. See, it was there.
Me, it is, ma'am.
Anyway, it doesn't matter. We have some
Shall I play again,
we
ma'am?
have some
From where should I
takeaway
play?
points from it.
Ma'am,
Here
I'll
it
play it
is.
again. Don't worry. From where should I play?
This part was there where we missed.
Yes.
Shall I start?
Yeah. Just a little more. Just a little more. Yes, just a little more. A little more. The turbulence part is there. A little more, sir. Just
More means
before
on the
I'm
right or
doing
on
my
the left?
IA.
Towards the end or towards the beginning?
Before removing the
Behind.
hooks.
Go behind. Little
Towards the
earlier.
left. Towards the left. Yes. Go a little more, sir. Left
Okay,
here.
ma'am.
So here
I'll
I
start
was
from here,
doing
ma'am.
it and start. I'm sorry I'm losing so much of time. Anyway, we've used optimal force to keep the iris away and taut and use the repositor. As I said, I usually do this whenever the iris is traumatic and use a 5th hook for this. And phaco was not very eventful. We could do it easily under direct supervision. You have to look out for turbulence. There should not be much turbulence here. As you can see, otherwise the hooks might get dislodged, which had once been there. And as I said, if we can maintain a good fluid, can maintain a stable anterior chamber and do everything, even I get a beautiful cap back here. And then the next step was quite easy. Going in the IOL, again I used that spatula to glide over my lens so that it does not go and hit the iris here and there. And the surgery went finally cool. But another very important point here would be how we restore the normal anatomy and removing the hooks very carefully. So as each step we do, we have to be very, very careful. The iris is flaccid, should not traumatize it. Hooks are usually pulled out gently in the direction opposite to the insertion. That's what I did. And at the end of the surgery was approaching, which was looking much normal than what I had faced in the initial beginning. So I close the eye with a round pupil. I have just some pearls to share with you, and they are that we need a control fluidics. First of all, we need the end part of the video, sir, is again not there anyway. So you can stop sharing. I'll just share the pearls where You need to plan ahead if you have a history of use of alpha-1 antagonists like tamsulosin or okay, I have my video cannot be switched on. Anyway, doesn't matter. And you have to you have to be equipped with pupil dilators, hooks, high density viscoelastics with you when you are dealing with such a patient. For me, this patient's other eye was traumatic, surgery was uneventful and had a very good recovery. So I was not expecting, but fortunately I had the things there. Secondly, the fluidics part has to be very well controlled, very high vacuum. Too much of fluid should not be pushed in, because with the turbulence, the hooks get dislodged or you cannot get a stable entry chamber. If you do too much of activity inside the eye, it is good to use second instrument frequently to avoid much trauma to the iris. And finally, as I said, we can use some other expanders like BHEX, but I usually prefer to have hooks which not only expand but also keep the pupil taut. Thank you very much, ARC and Chitra ma'am, for bearing with me and all the audience here. Thank you all.
Thanks a lot, Dr. Sudipta. I think network issues are something beyond us. Going on to the discussion part of it, I would want to ask, we start with Dr. Mohan. So what are the essential preoperative measures, which of course she must have not expected this to happen as the other eye was uneventful, but in which eyes would you want to give some, do something about decongesting the vitreous? Which kind of eyes would you do or take an extra preoperative step?
No, I think she managed it quite well. I just want to what is the action length of the patient? She said it's hypermetropic, but more importantly, I think preoperatively, the history is very important in all these patients. Many patients don't tell the history properly because they do not know the relationship between anti-prostate agent and the iris. So even the physicians may not know. So you have to ask for a specific history, whether they are using tamsulosin or I don't stop the. In fact, stopping is actually sometimes dangerous. You can produce urinary retention. So atropine also I don't use. Only thing is I take all the precautions. My cutoff level is about 6 millimeter preoperative. If the patient does not dilate beyond 6 millimeter, straight away I use iris retractors, either in the form of iris hooks or mulligan ring or BX ring. So whatever the
If the eye is hypermetropic, I think who could give an oral glycerol to these patients. And that would definitely make it a more comfortable surgery. Stopping the tamsulosin does not help. Dr. Kapil Vora, would you want to add something?
Chitra, I would like to restrict myself to the management part, please.
Yes.
What I would have done was, Sudipta has managed it beautifully. She has managed it very well. And I advocate the use of iris rings rather than the dilating devices, because the dilating devices could dilate the pupil up to 6.5 millimeters. Again, this, the floppiness will be there. But with the iris hooks, of course, you can pull them right to the periphery and the problem will not be there. The first thing that I usually try in my cases is I go to the side port and do a vitrectomy, an iridectomy right under the main port. So it sometimes helped me during the initial stages, and there is not much prolapse of the iris because most of the time the constriction of the pupil follows the prolapse through the main route. So this is what I usually do in my case as a first step.
Actually, you could even place 2 hooks on either side of the main incision, and that itself stretches the iris between these 2 wounds, and that could be done. Yeah. And I think the side ports should be just 0.9, should not be larger side ports. It should be a little longer and it should be more posteriorly placed so that the iris doesn't come and plug those side ports. And we should not overfill the anterior chamber so that the eye doesn't get too tense, and a cohesive viscoelastic should be used, and either we keep 4 hooks or 5 hooks or something. In other words, our threshold to using pupil expansion devices, as Dr. Mohan had said, and as Dr. Kapil has, be so low that the least bit of doubt we start. But again, if you are caught in such a moment, sometimes it's even makes sense to, if they're physically all right, to give an injection mannitol to further decongest the eye. If it was more traumatic than what it was, you could do that. Dr. Ramurthy, your thoughts?
I think nicely managed and most points have been covered. I would have made slightly longer incisions. And, I would, all of you mentioned about using cohesive viscoelastic, maybe in the initial phase to deepen the anterior chamber, but later on it's better to use dispersive viscoelastic because these cohesive viscoelastic will tend to come out as a bolus. And the most important point to remember is that, it is not the prolapsing of the iris which damages the iris, but it is the reposition of the iris that damages it. And Dr. Sudipta also pointed out, maybe it's always, attractive to just push the iris in through the main incision itself. But it's important that you let out fluid and go through the side port and gently reposit it. And one thing is, once you catch hold of the iris and the damage is done, then you get into a cycle where it keeps on bothering you right through the surgery. And needless to say, all of us know that gentle phaco, lower parameters that is most important in these situations.
And if you're already aware that this patient is on these drugs, or even if it's a diabetic or hypertensive, it makes sense to give atropine eye ointment before the surgery if you are well aware that you could be facing this challenge. And nowadays, people would think of using phenocaine also on the table because this causes the atropine ointment prevents the pupil from constricting, and phenocaine, what it does is it tautens the iris and the dilator muscles. So that would also prevent the floppiness from happening to an extent, along with all that was said. That was a nice
Atropine
case.
is a little controversial.
Yeah,
Atropine is a little controversial. We personally don't do that, though some people describe it, because sometimes that itself can cause urinary retention. So it might be a good idea to avoid it and just use the gentler dilating agents like phenocaine, what you mentioned.
Chitra, I'll just add one quick point.
Yes.
I know you're running short of time, but when she showed that video, so that when you put the side port, she put, I think, HPMC at that point of time. Don't use, for heaven's sake, don't use HPMC when you are suspecting a patient with an IFIS. HPMC makes the pupil a little more floppy. So HPMC, the way to go is to go for the sodium hyaluronate, or even Viscoat is probably the best. And don't overinflate the AC. If you overinflate the AC, more and more iris will start coming out. So just have enough Viscoat. Just push when you have iris coming out, just reposit the iris from the side port and just put some Viscoat at the main port and push the iris there. And then go in. Go in without the infusion and come out without the infusion. When you go in without the infusion, come out without the infusion. When you come out without the infusion, the iris will not come out with you.
Yeah, so
correct, sir. I was using HPM at the beginning, and later on I switched over.
Yeah.
Yeah.
So anyway, thank you very much. We shall now go on to our next speaker, Dr. Siddharth Ghosh, who's a senior ophthalmologist from the Nightingale Hospital, Calcutta, and he has again a very interesting video. A great learning was going to come through it. On to you, Dr. Siddharth.
Thank you, ma'am. Thank you, Dr. Chitra, for giving this opportunity. Am I audible and is the video visible?
Yes.
Right.
Yes.
Okay. Good afternoon, everyone. And in the next few minutes, actually, we're going to discuss about true complicated cataract. And this is how we call the uveitic cataracts. This 46 years old male had recurrent episodes of anterior uveitis in both eyes. But now he is quiet for about more than 3 months. When he presented with gross dimness of vision in the right eye. And as you can see, there is posterior synechia. We make the incisions, and with a blunt spatula, we try to do synecholysis and under viscoelastics, of course. And once this synecholysis is done, I try to peel off the pupillary membranes. Unless we peel off the pupillary membranes, we cannot stretch the pupil. Once that is done, we go ahead and put some more viscoelastic and then mechanically stretch the pupil with 2 devices so that we can implant a pupil expansion device. In this case, I have just put it in and I have tucked the pupil underneath the flanges so that the shape is maintained and so that we have adequate visualization for a good capsulorhexis. And then under the viscoelastics, I start painting the white anterior capsule of the white cataract, and then again once the stain is taken up, I use more viscoelastics to clear up, and gradually I fashion a capsular rhexis as large as possible in this situation. And, it should be adequate. In all uveitic cases, post-uveitic cases, we need to make adequate size of capsular rhexis. And you can put in more viscoelastics whenever required and grasp and regrasp to make sure they don't go to the periphery. It's a wide cataract, as you can see. And once that is done, a routine hydrodissection. And as you can see, it's more of a soft cataract, which will not crack as well. And it comes out as flaky material. And really, I have used very little energy because not much was required. It's a very soft cataract. Once that is done, we do more, irrigation aspiration to take out all the white material, the cortical material. And once all the cortical material is thoroughly cleaned, we need to make sure that we clean up all bits that is visible, that is possible, so that they don't react later. And once that is done, you can see that maybe there's a little D-shape of the rhexis, but it's adequately sized. And I put in a hydrophobic acrylic intraocular lens in the bag. And of course, we need to expand the pupil expansion device now. It's very simple to take it out. And once that is done, we need to thoroughly clean up all the viscoelastic that we have used, and also from behind the IOL. That is important. We cannot leave a little bit behind the IOL as well, so that it doesn't be the nidus for more cells to get accumulated. So the lessons learned in this case was that synochialysis and pupillary membrane removal is very important. And anterior capsular painting with trypan blue under viscoelastics is important for good visualization. And we need to use judiciously any of the pupil expansion device to achieve adequate size of capsular rhexis. And of course, the choice of IOL in these uveitic cases is very important. Thank you so much.
That was a superbly wonderful video, Dr. Siddharth Ghosh. Actually, you've told us everything which is there that to be done during the procedure you have explained. So I think we have to go on to a different mode of discussing the theory behind the uveitic cataract. So the question which I would want to ask the expert panel or even Dr. Siddharth, whoever, what I want to know is, what kind of pupillary dilating drops would you want to use in these eyes, and why? Like,
ma'am, you're asking me?
Yes.
Okay. I generally try to, if it's a long-standing event, like old, we know that there are a lot of synechia. I would like to use atropine even initially, because they have already received that maybe earlier, but this time I wish to. But even then, these synechia won't go away. So we need to be prepared that we will need to do synecholysis intraoperatively, and that should be the first step. Now, some people would prefer to do it under, BSS, so that they can stain.
Post-operatively.
Oh, post-operatively, sorry. Post-operatively, I use homatropine for a long time, at least 10 to 15 days, so that they don't get synechia later. There is no pupil addition to the IOL. And that's why you need to make a bigger rhexis as well.
Yeah. Also, we want the pupil to be mobile. So if the inflammation is extremely well controlled, there is even a logic in using a tropicamide drops and use it 3 times a day or something. And if you want an inflammation control, because you expect a smoldering infection to be occurring in the post-operative period, then maybe a homide would be the better way to go. Then as far as the management of the, whether you want to give, when would you think of giving oral steroids? When would we want to give intravitreal steroids? When would you want to keep them only on topical steroid? I would want some thoughts of Dr. Mohan, Dr. Ramurthy in
this case, Chitra, I would like to congratulate Siddharth for the wonderful video.
Thank you, sir.
Yeah. But what I would have done differently in this case, I would have used intracameral tricot at the end of the case, and also subtenon skenacot I would have given. And if the patient has got intermediate uveitis, a complicated cataract, then I invariably give intravitreal Osidex as well. So, but in this case, anterior uveitis only, the posterior segment is fine. Intracameral tricot and all other things, I think I will agree with you.
As far as the oral steroids are concerned, in the case of uveitis, like I would just going to give a short summary. I would want you all to add on your thoughts to it. See, this complicated cataract, when you see, it could be a case of just an anterior uveitis, wherein you need to keep the patient, wait for eye to be quiet for 3 months and start them on oral steroids, the topical steroids, a week or two before, and keep them on continue the medication, would taper the oral steroids over a period of time, and not those very mild uveitis, the most significant uveitis. It could also be that anterior uveitis is happening and there is no fundus view is there. Then again, you are not aware of what is the etiology behind this. Then again, you should be starting the patient well in advance with oral steroids. And then there are some surgeons who would also like to give subtenons, as Dr. Mohan had said. But there are situations where you can see the fundus and you know that there is a fundus pathology here, then it makes sense to give Osidex injection even a month back, treat the macular edema, and then go ahead and do a cataract surgery and follow it up. And if this patient is on immunosuppressants also, you need to start oral steroids if the patient can tolerate it, if the patient's immunosuppressants have been stopped by any chance, and keep them on oral steroids, start the immunosuppressants because they start kicking in after a month, and then gradually taper the oral steroids and then continue the patient on immunosuppressants. So essentially, when you just see a complicated cataract, you need to go into the history of the patient. And there are some patients who could even have a phacoanaphylactic kind of a reaction when you need to take the cataract out along with pumping in all the steroids, oral, topical, subtenon, and everything else. I want expert panel to please add on whatever they want to at this point of time. Anything else to add?
Congratulations, Siddharth. I mean, excellent surgery, very well managed. Just for the sake of only point I might have done differently is that, as you rightly said, it's not just the synovial lysis, but the removal of the membrane is most important. And it also depends on the timing of your dye injection will depend on the type of viscoelastic that you're using. Most often, many of us are using HPMC. In that case, if I'm planning to use HPMC, what I do is to just inject an air bubble through the side port and then go through the and release the synicate through the side port using an iris spatula. Inject the dye under the iris and then subsequently go ahead with the rest of the steps that you showed. It's simply because if you have HPMC there and then subsequently you use dye, then the dye doesn't take up too well. It becomes too granular. So the kind of painting that you showed is possible only more under cohesive viscoelastics. So specifically that needs to be used. Otherwise, surgically, I have nothing much to add. As Chitra was pointing out, I think now, except for those complex cases of uveitis which have undergone a uveitis workup and we are managing it along with that expert, then immunosuppressives, oral corticosteroids, etc., may be necessary. But most often, I think nowadays with the availability of intravitreal long-acting dexamethasone, that injection often takes care of recalcitrant uveitis for a significant period of time. So adding on a PST, posterior subtenons, tricot, or a intravitreal Osidex most often takes care of inflammation. Of course, putting on a cycloplegic for a couple of weeks after the treatment, and maybe starting with 8 times drops and slowly tapering it down. A little more than what we would for a conventional cataract surgery. It's what's needed in these cases.
Dr. Rohit Omprakash, you have joined in. You want to add something?
I just joined in. I didn't see the case from the next. Yeah.
Okay. Dr. Kapil, would you want to add or shall we go on to the next video?
Let's go on to the next case since my screen has also gone blank. Okay. So I'll be rejoining.
Okay. Okay. So we have our next speaker, Dr. Lakshman Singh Challa, who's a medical director of Alak Nayan Mandir, Udaipur. And he's got another very interesting video to show us, and let's hear from him. On to you, doctor.
Thank you, madam. Good afternoon to all of you. So now I'll be presenting a case. As we all know that IOL opacification is a late but uncommon but a serious complication. So here is a opacified IOL, and the surgery was done 8 years old, and this is a hydrophilic lens. And
Show the video.
pardon?
Open the video.
Please open the video.
You are unable to see the video?
No. I hope you have kept the video open already and in pause.
Mhm.
Then you
First
share
open
your
the video,
screen.
then share the screen.
Just a minute. Can you
If
see now?
shared your desktop, you shared your folder.
Can you see the video or not?
We don't. I think, Dr. Challa, I'm going to ask Dr. Anand to talk to
Yeah.
you.
I'm
And
doing
then-
it, ma'am. Give me a moment.
Or you,
Yeah,
or you can
Anand-
play the
Anand-
video. Maybe let Dr. Anand Sethi play your
Yeah.
video and you could talk.
Okay.
Give me a minute, please.
Have my video?
Yes, he'll play it. Just a moment. You could start.
So here is a case of IOL opacification. As we all know that opacification of IOL is uncommon but a serious complication of cataract surgery. It can cause significant deterioration of the visual performance and may necessitate IOL opacification. So this is a patient who got operated elsewhere 8 years ago, and we tried to protect the bag or retain the bag, but because it was 8 years old, so there was lot of epithelial cell growing and lot of fibrosis of the IOL, and we were unable to take out the IOL and unable to retain the bag. Yes, you can see that we are trying to free the IOL from the bag and retain the posterior capsule in the bag, but we are unable to do that and we are struggling. And you can see that there is a zonular dialysis also. So we planned to take out in toto the bag with the IOL. In spite of all our efforts, we were unable to separate the bag and the IOL. There are different types of IOL opacification. It's different in the PMM lenses than silicon and hydrophilic. It's very less in hydrophobic IOLs. Of course, there is glistening, but opacification is very rare. Now you can see that we are trying to take out the bag with the IOL. And we have planned for a iris claw lens, which is to be implanted posteriorly or tucked posterior to the iris. So we have planned to, instead of cutting the IOL, we plan, because it has a 5 millimeter optic of the iris claw lens. So we plan to enlarge the section 5 to 6 mm. And then instead of cutting, we will try to pull out the lens. You can see here that we have made a 6 mm incision. Enlarge the incision. And we have pulled out the lens with the bag. A limited anterior vitrectomy is needed now. So you can see that we are doing anterior vitrectomy. Then putting little bit of pilocarpine, intracameral pilocarpine after the vitrectomy. So that pupil is round and constricted. And now we'll try to implant the iris claw lens. We have three options, either to put an anterior chamber lens or a iris claw lens being tucked posteriorly or anteriorly, or we can implant a scleral fixated IOL. But we are, as an anterior segment, we are comfortable with the iris claw lens, and we have found that it has good results with minimum uveitis and pigment dispersion. You've done very well after doing perfect vitrectomy. You can see that pupil is round. This is a special forceps to hold the optic of the IOL and then put it posteriorly and then tuck the iris on one side. This is the retrofixation of iris globe IOL. So in this type of opacification, the first choice will be to explant the IOL and protect the bag and exchange it with another hydrophobic IOL, but we could not succeed in doing that. So we had to pull out the IOL and the bag, and now you can see that the lens is very well placed and wound was closed with intracameral antibiotic, and patient was 6/12 the very next day, and we are following him. This surgery was done 15 days back only. Thank you very much.
A wonderful video, Dr. Jalla. I showed it, and you showed all those challenges of trying to save the bag and how you had to take your change of decision. My thought was maybe that portion got edited, but when you're doing a vitrectomy, wouldn't you want to close your main wound when you do a vitrectomy?
So this main wound was not closed at that time. It was 5 millimeter, but vitreous prolapse was very less, and ideally we should close the main wound.
Yes. Dr. Rohit, I want your thoughts on these opacification of IOL. Do you think these happen more with the hydrophobic or the hydrophilic material?
I think they're coming up more with the IOLs which are hydrophilic in nature. And this is what I have observed. But then, you know, these glistenings are there in hydrophobic IOLs as well. The case was perfectly done. I would have, you know, tried to be more, you know, what differently I would have done is that I would have tried to be more discreet, in the sense I would have used a flat spatula to start with and tried. No doubt it was 3 years old surgery. The adhesions are there.
8 years old. 8 years old.
8 years old. But still, you know, I would have been more patient, more cautious in breaking the adhesions around the capsular axis all around. And then, you know, with the visco, I would have tried to, you know, expand the bag and try to rotate the IOL if it could have been possible. I would have tried to, by all means, I would have tried to save the bag, and I would have tried to lift the optic and cut the haptics at the optic haptic junction also. And then, you know, by opening up all around, try to put an IOL by exchanging the IOL and put in the other IOL. That would have been my first. But in such a situation wherein such a long period has elapsed, there is no other way out. And I think it was perfectly managed by him.
Actually, sir, this was a Rayner type of hydrophilic lens. So a lot of epithelial cells have grown in between the gap between the haptics, and it was totally fibrosed. So we have also tried a lot, but we could not succeed.
Absolutely. I think it was perfectly done, because if there is no way out, that is the only answer. Absolutely.
As far as anything to add, Dr. Mohan and Dr. Ramurthy?
No, I think you did a good job. But what I would have done is, I would have done all methods to preserve that capsule. One important thing is, because we have reported 26 cases of hydrophilic lenses, a lens called GDR, which is called MDR in the US. Way back in 2002, we have also presented a video called whitewash at that time. These hydrophilic lenses are actually easy to remove. Okay. And you can even actually fold it up, bring it up, and remove it through a very small incision as well. The only problem is, if it's adherent, what I would say is to use a cohesive viscoelastic. Go all round, open up the capsular bag, use a cohesive viscoelastic like Hyalon or even Disco Whisk, which will expand the bag very nicely. And then you will create a cleavage plane between the capsule and the optic of the lens. Another important thing is, if you're not able to do that, as in this case what Jella did, I will use micro scissors to make small openings in the anterior capsule. The openings will actually open up the anterior capsule a little, relax the anterior capsule a little, and then then you can put viscoelastic and prolapse sometimes the optics can get adherent. The optic will never get adherent. The optic, you can just, as Rohit rightly said, you can just push the optic up and then cut the optic junction and remove the optic alone, and then put the new lens in the back. Because nothing like having a lens in the back or in the sulcus instead of having a retro-iris fixated or scleral fixation. And anterior vitrectomy, of course, I would have used tricot definitely to make sure that the vitreous is removed. Otherwise, everything is fine.
I think I echo what Mohan said and what was said by Rohit also, but very well managed, Jala. But it's the ultimate outcome which matters, and you got good results. But I would feel that, I'm quite surprised in a hydrophilic lens that additions were so dense. Most often you come across in hydrophobic lenses. Usually in hydrophilic, even after years later, you are able to easily separate them and bring out. But then we saw what was happening. And as Rohit said, I would have been a little more gentle in my handling. And sometimes if you are able to insinuate your the iris spatula between the lens and the rexis almost all around. It was the haptic which was absolutely stuck. In these cases, scissors can be used, as Mohan said, or I wouldn't have even hesitated to go with a vitrector and create a small nick under the area of the optic haptic junction. If I'm able to create an area of separation, then it's sometimes in these dense additions impossible to remove the haptics. But then if you cut the optic haptic junction and just remove the optic, and maybe even place a 3-piece lens in the sulcus. And as was observed, I think in today's world, any vitrectomy done for any reason should be completed with translucent. That's what gives you an idea that it's complete.
And a PI could be done for an iris clip lens makes a lot more sense, because the post-op IOP spikes due to pupillary block would be well addressed. And what would happen now? Normally, glistenings are more common in a hydrophobic, and calcifications are seen more in a hydrophilic lens material. And there have been given explanations because the variable water content and microvacuoles which cause these glistenings. Now, if it is a very long-standing case, do you think that because of the tackiness of a hydrophobic IOL, it might be more stuck to the posterior capsule as against a hydrophilic? So getting a hydrophobic IOL out would be a bigger challenge than a hydrophilic.
Definitely.
100% yes.
Definitely.
100%.
Hydrophobic IOLs are also, they have different subtypes.
Yes.
Some have a lot of tackiness, like Alcon one has, whereas there are others which do not have much. But definitely hydrophobics offer a bigger challenge. No second thought about it.
When there are glistenings on the IOL due to variable reasons, it's not just the IOL material, it's also if the blood aqueous barrier is disturbed in even in diabetics or inflammation and all that. Would you want to go ahead and remove the IOL just because there are glistenings, or would you do it?
I was just about to ask Dr. Jala, what was the vision in this case? What was the vision?
Pre-op was 624.
Okay, because sometimes, kind of glistenings you see, the patient never complains. You see it only on the slit lamp. And maybe the contrast is low, but if the vision is reasonably good, it's best to leave it alone.
So, Ramurthy, there's a difference between glistenings and opacification.
Yes.
Please, glistenings can be associated with fairly good vision.
Yes.
We have plenty of patients, acris of lenses, good vision. Only thing is the night vision may be affected a little. They may have a little glare, but they don't affect the visual acuity as such.
Yes.
Opacification is the problem.
Yes.
Yes.
Opacification, this was an opaque lens, had to be removed.
I would like to add is, please, when you suspect opacification, don't yak them.
Yes.
Please don't yak, because many people think it's supposed to capsule opacification and yak it.
The lens
Yagging
material.
it, you are adding fuel to the flame.
Yes.
Because you are going to have an open posterior capsule when you're going to remove the lens. That's going to have more problems.
Yes.
That's right.
And Dr. Vineet Joshi, are you there? Dr. Vineet?
Yes. Yes.
So you are the cornea guy, so I wanted to ask you this question. Would you ever think a hydrophilic IOL, along with if it has had a DSEC surgery or a DMEC surgery, where there has been an air injection, do you think that these hydrophilic IOLs can calcify? So do you have anything to add on that?
Yes.
Yes.
Yes, we have seen this, and to support this, there was a case series from UK where they found that when you inject an air bubble, there is certain change in the calcium and.
Yes. Yes. Maybe you should switch off your video. Suddenly we can't hear you. Dr. Vineet?
His network appears to have gone.
Become unsteady. So essentially, if there is an air injection or an intravitreal gas is being used in these corneal procedures, intravitreal procedures, it has been seen that there could be a calcification which occurs. Yes, Vineet, can you talk now? Who is not able to talk? So there could be calcification which is seen more in a hydrophilic lens material. And of course, glistenings, as was earlier said, could be watched if it is not having a visual impact, and though glare could be a bother in some of these eyes. I think I'm sure we lost out on discussions from Dr. Vineet. We shall now go on to our next.
Vineet is back, ma'am, if you want to.
Yes, Dr. Vineet, you want to add anything?
Yeah, that was the point. I'm sorry, I just lost connection.
Yeah. So you didn't have anything else, no? This is what you had to add, right? Okay.
Yes.
So we shall now go on to next speaker, Dr. Mayank Agarwal, who's a leading senior consultant practicing at Jindal Eye Hospital, Jaipur. And he has another very interesting presentation to show us. Dr. Mayank, are you connected? Hello?
Can you hear me, ma'am?
Yes, we can hear you. You could share your video.
Yeah. So I'll be presenting a case, which is normally to all of us, it's a challenge. So it's a intumescent hard brown cataract. So I started with the neck and aspirated the fluid, then flattened the intake capsule by the viscoplastic. And now the NTA capsule is flattened enough so that I could make a good rhexis of around 4.5 to 5 millimeters in one go. Now you can see that it's a very hard leathery cataract. I usually make a 2.2 millimeter single planar incision and just go straight. I don't do a hydrodissection because the fluid has come out. I'll just check by rotating the lens that it is freely rotating or not. It is freely rotating. And then my preferred technique to do is a stop and chop. So I make a deep trenching so that the most of the core of the nucleus is being taken out initially, and then do a chop. The terminator chop, as advised by Dr. Rajendra Prasad, I am not doing that. I am just giving multiple chops to the nucleus so that this central core comes out. You will see that soon. I am giving multiple nicks at the periphery. And without putting much pressure sideways. And the core now is getting separated. Few more nicks and it will come out. You see that now this core I can lift up. Now this core is being lifted up, been divided into small pieces and eaten up. Now there is a lot of space inside the capsule bag. So my maneuver will be, I can make more lateral movements if I have got space. Still it is very leathery, not dividing to the fullest. So I try to take 1 or 2 pies, leaving the central attachment still on, which will be taken out later. So it's not, see, it is not being divided, still not divided, still attached at the center. Now for few cases, I do a horizontal chop like this, where I move my chopper from nasal to temporal side and separate it from the center so that I can take the piece out. Now everything is being divided and I can take a good sigh of relief. The settings, normally I keep my phaco at 50% phaco power and vacuum of around 400 in these cases. It is important to make even smaller pieces. It's a little fast forwarded and high speed video, so you cannot appreciate all the things. And a 3-piece hydrophobic lens is being implanted into this eye. Thank you.
Thank you very much, Dr. Mayank Agarwal. That was a very difficult, challenging case, and each of us have to get innovative into how to deal with it. And there was some amount of intumescence. I'm going to ask Dr. Kapil first to comment on what are the tips which we need to have in mind when you're doing a hard cataract, and also there is an intumescence there.
Thank you, Chitra. The first thing that I would keep in my mind is to make an adequate sized section, because however low power we use, we have to use it for a longer period of time in hard cataracts, and there are chances of wound burn even with the finest of machines. Number two, I would like to keep my rexus at around 5.5 millimeters rather than 5 millimeters. It has to be slightly bigger so that you can, handle these kind of nucleus easily. The size is bigger, almost there is no cortex existing in such cases. But the advantage with these kind of things is that once you have entered the nucleus, it cracks very easily. So every surgeon has his own style, and I am comfortable with going very deep into the nucleus. I don't go up to the periphery, and I try and crack it. And most of the times I find that the crack extends to the other end also. So I still divide it into 4 pieces or 6 pieces and take out tip by tip. But then again, the doctor has demonstrated a very good technique to separate out the hard nucleus from the center, eat it first, and then rest of the things will follow automatically. So what I do is that one thing to keep in mind is that we are chopping the nucleus and not the cortex. So we have to be very deep in these kind of cases into the nucleus, and we have to destroy the nucleus. Thank you.
Yes, wonderfully said. Dr. Ramurthy?
Yeah, I think Kapil has said most of the things, and a nice presentation, Mayank.
Yes.
All I would say is that, one thing that bothered me was that there was no distinct separation. In these hard nucleus, the most important reason is to get a through and through chop. And, we have to see the chop extends right through. And what I do normally is to, in the subinterstitial area up to the center, create a fairly deep trench, have at least 1.5 millimeters of my tip exposed, get a nice purchase, and chop the nucleus. And I want to see the chop going right through, and so that I can see the red reflex behind. In case that does not happen, in some cases, very hard nucleus, sometimes even in very soft cataracts, you can't get that. So I just go ahead and extend that right through and convert it to a stop and chop like what you're doing. Sometimes even go with 2 Sinskey through the 2 side ports and get 2 heminuclei distinct. What I want is to break the backbone of the nucleus. You had something like a flower petal. You did manage to take it out, and I'm sure the final outcome was good. But then if you're able to separate them, whether it's into 6 quadrants or into 2 heminuclei, and you can see the chop propagating right through, the whole surgery proceeds in a more controlled manner. Of course, I'm sure maybe it got edited out. In these cases, I use a dispersive viscoelastic and often refill. That's to protect the endothelium. And secondly, the Sinskey hook is slightly inside. When the nucleus fragments invariably come out, I use it to protect them from hitting on the back of the endothelium. That ends up with a slightly clearer corneas in the postoperative day.
Dr. Mohan, without repeating what the other 2 expert panels said, you have anything extra to add? That was good, Dr. Mayank. That is a courageous surgery.
Yeah, I would have done puncture rexus, because the advantage of puncture rexus is that you can get a bigger rexus, whatever you want. Okay. And another thing is, I would tend to agree with Ramurthy that you need to use a sharp chopper. Maybe my chopper, Mohan Rajan chopper 1.75. Maybe go, because you need to go. What I do is I do a vertical chop, because there's nucleus and more nucleus in this case. 8 to 10 millimeter nucleus size is there. You need to go all the way down and see the posterior capsule through and through. The posterior capsule has to be seen through and through before you. And I first divide the cataract into 2 halves, chop one side, rotate 180 degree, chop the other one, so that I get the two halves, then attack each of these halves, make it into smaller pieces. If you try to take this without cutting the posterior nuclear plate out, the entire nucleus will start coming out like what you have seen in this case, and you will have a white cornea the next day. So that is the thing. So because these nucleus are very, very bulky, you need to make it smaller pieces, make sure that the chop goes all the way down. Now and then replenish with viscot into the anterior chamber.
Yes. Thank you, Dr. Mayank. Be with us. A lot more interesting videos along the way.
Thank you very much, ma'am.
Yeah, thank you very much. Nice video. We shall now go on to our next speaker, Dr. Thomas George, who is a senior consultant at Chaitanya Eye Hospital and a very leading cataract and glaucoma surgeon from Chaitanya Eye Hospital, Trivandrum. So he's going to show us another very interesting video. On to you, Dr. George.
Thank you, Dr. Chitra. I'm going to share something that I wouldn't wish on my worst enemy.
Your mentors may leave you prepared, but they can't leave you ready. I learned the real visceral difference between preparation and readiness.
Good morning. You can be prepared as much as you want, but you're never ready for some situations. This case started as a routine dream cataract of any cataract surgeon, but soon things took a turn for the worse. The anterior chamber shallowed almost immediately after we started phacoemulsification. Soon the chamber was shallowing, the pupil was no longer round, viscode, helon, viscode, nothing could keep the chamber formed. And putting in viscode this time made things worse. I thought visco had gone behind the pupil, but taking it out only made things worse. So I had to send in iris hooks to keep the pupil dilated enough for me to see what's going on, and I somehow managed to take a few chunks of nucleus out with great difficulty. As you can see, the capsular bag is lax and rotation is difficult. Once I saw the red glow, I could see that the posterior capsule was convex and not concave, and this was not a silicone oil eye. So I put in viscoat under the nucleus, hoping to send the PC away from the nucleus, and a PC rent developed. So I lift the nucleus pieces out in the AC with the intention of bailing out, extend the wound, and nucleus pieces are taken out with a vectus. By that time, vitreous had presented itself into the wound. What I did not notice on the table, but noticed on reviewing the video, was that the vitreous was pulsating in the wound. Transmitted pulsations were there in the vitreous that's prolapsing out of the wound. Anyway, I had an intact rhexis, so the cataract surgeon in me told me I can do a good vitrectomy and put a lens in the sulcus on top of the rhexis. So that's how I proceeded. Soon something white started peeping up from the nasal side. I had not dropped any cortex. So it took me some time to realize that is the ora serrata and the choroid behind. So quickly deciding to close the wound, I asked for sutures. And the sister calmly asked me, why do you want sutures for a phacoemulsification? Well, I lost my cool and luckily she did not. Eventually, the sutures did come in. I took out the iris hooks and managed to close the wound with a central box suture. And that alone was secure for the wound, but I went on to put a continuous suture to close the entire wound also. We waited after that for 1 month and the hemorrhage mostly resolved. We did a pars plana vitrectomy and placed an intraocular lens in the sulcus. A nasal crescentric TRD was there, which was left alone, and that after 1 month became a giant retinal tear with an RD. A repeat procedure was done And the final vision was 612 and 6 months okay so far. Thank you.
Thank you very much, Dr. George. That was a very challenging video which you had shown. But on hindsight, what could have been done differently as to what you did?
What was the reason for this? Was there an expulsive choroidal effusion in the beginning?
Yes.
Luckily for me, it was not an expulsive in the form that nothing expelled too much, but it was a suprachoroidal hemorrhage. And this patient is well into her 80s, and I am primarily a glaucoma surgeon. So this was planned as a cataract with trap. So to start with itself, I had a pressure that's in the 20s, patient in the 80s, enough risk factors.
Yeah.
And
Yes.
because of the cataract, I took some time to realize what is going on behind.
Yes.
And I've actually highlighted where all I should have thought.
Yes, essentially, she was also a hypertensive. I think you might have been a bit of a challenge whether to start mannitol. Maybe when the eye was getting to be as tensed as this was, you could have given a mannitol to this patient and brought down the pressure, because this is probably not the case where you can do a pars plana vitrectomy to lower the IOP, because that would be hugely hazardous. You could get a decompression retinopathy kind of a situation. I want the thoughts of Dr. Kapil, Dr. Ramurthy.
I think I should compliment Dr. Thomas for showing this case. Obviously a very difficult case, and he had the guts to show it and also highlight the complications. I am not the initial, because it started out as a walk in the park case, as he mentioned, routine case, and then it ended in difficulties. When such an upthrust is there in a routine case, I would not hesitate to go ahead and do a limited anterior vitrectomy, go through a pars plana route and decompress the vitreous, and then things are likely to settle down, and maybe go ahead and do the rest of the surgery, because this was not a complicated case to start with. And second point is that when you had opened up the incision, and before doing the vitrectomy, I would have definitely closed the incision. Especially, you could see whether you notice the pulsations or not. The lips were not really getting opposed. In that case, with an open wound to go ahead, it's inviting trouble, suprachoroidal hemorrhage, or even suprachoroidal effusion, which you ended up with. And I think this case also highlights the point that, going in with a wire victis and trying to remove nucleus, all of us do it sometime or other. Let's admit it. Obviously, it causes a lot of traction on the retinal periphery, and that's the reason you ended up with a giant retinal tear subsequently, and it ended up with a problem. Especially in an institution like yours, where readily vitreoretinal support is available, maybe allowing them to take care of these cases when you land in a situation like this might be a good idea. I would just say that maybe initial anterior vitrectomy to decompress the problems you had subsequently, and when you had to do vitrectomy, going ahead and closing the main incision, and maybe once not using the wire victis might have been good idea, good thoughts you could have adhered to. But especially when you noticed a TRD, maybe at that time itself, it could have been dealt with instead of waiting for the patient to go ahead and have further complications. So you did mention that was only nasally, and maybe that was not initially impinging on the vision of the patient.
I think I do agree with what Ramurthy said, but I would feel that a mannitol is all should have been given, and you do not go in and do a pars plana vitrectomy. Eye with a high pressure and sudden lowering of pressure can be hazardous to the posterior segment. But what could have been done is, when you do need to do an ultrasound to see how the suprachoroidal hemorrhage is evolving, stop the blood thinners, and check lower the BP, do all of these things. And probably, as he had said, traction could have been dealt with at the second sitting when you did the surgery, and probably a tamponade could also have been created so that a laser could have been done, so that you don't need a second sitting of the surgery. Anything, Mohan, you want to add?
Actually, when you see an upthrust like what, it was a walk in the park case, as Ramurthy rightly said. It was a straightforward case, but there are risk factors. Age, arteriosclerosis, hypertension, and glaucoma patient, all these are risk factors for expulsive. Okay, but when you see, as soon as you enter, it is okay, but after some time, the AC becomes shallow and all that. what I would do is I will just not blindly put a vitrectomy probe there.
Yes.
I will not put a trocar and cannula. The simple reason is that I want to do an indirect.
Absolutely right.
Yes.
Absolutely.
Yes.
Can I come back on this?
Yeah, I will do an. Are you able to hear me?
Yes, yes.
I will do an indirect ophthalmoscopy on the table, and then probably decide on whether to put a thing. If we don't see anything in the choroid, like an expulsive effusion or something like that, then probably decompressing the vitreous. I'll just put a trocar and cannula, but I will not put the vitrectomy probe inside. I'll just at the what do you call, at this entry site, I will just do what is called a vitrectomy there and decompress the vitreous. Of course, preoperative mannitol, intraoperative mannitol also, everything helps in this case. But just blindly putting a trocar and cannula is not advisable.
Yes.
No, I would tend to agree with you, Bhuvan, but the thing is, they had gone to the extent when the nucleus had already got hydrated. Even if you're trying to do a indirect on the table, maybe there would not have been enough view unless there was a full-fledged suprachoroidal which was there. Anyway, I mean, the different pros and cons to each step.
Yeah. Dr. Rohit, anything to add, or shall we go on? Yes, Dr. George, tell me. You have to add. Yes.
The thing is, looking back, I think that pulsating vitreous itself was because the bleed had already started.
Yes. Yes.
That is there. And I had called in the VR surgeon. He was operating in the next theater, and he took about 4 minutes to come to me. By then, everything had finished.
Yes.
I had made all my decisions and closed up.
Absolutely.
And I was there for the VR surgery because I was putting in the lens. That TRD was actually like a falciform fold. It was refusing to go back, and our VR surgeon, Dr. Manoj, who I think all of you know, decided that it's more risky to go after that now. We would end up putting PFCL and all, and we decided to wait on it, which was not a good decision finally, 1 month later.
It depends. Yeah, I think there were it's a very complex situation, and on hindsight, we could talk a whole lot of things. But I think
amazing video, Chitra. Amazing. Thomas.
Yes, wonderful video.
Fantastic.
Yes, Dr. George.
Thank you.
You just opened up a lot of things for us. I think the best thing to do is give mannitol if you can proceed with the case, or close the eye and wait for a better day. That's the main message here. We shall now go on to our next speaker, another very dynamic surgeon, Dr. Rakesh Shakia, who's the chief consultant and head of the Department of Glaucoma, and also a senior consultant cataract and intraocular lens services from Sadhguru Netra Chikitsalaya, Chitrakoot, and he has another interesting case to show us. Yes, on to you, Dr. Rakesh. I think Rakesh's video has to be shown from, okay, he's showing it.
We cannot hear you, sir. Dr. Rakesh?
Rakesh?
You're muted, sir.
Dr. Rakesh, you have to unmute yourself. Dr. Rakesh, are you there with us?
Yeah.
Okay. Then
thank you, ma'am, for giving the opportunity, and thank you, Rajan sir and Prakash sir, to actually thank you. So I am presenting a video of 38-year-old male and the history of the trauma 2 years back, and the temporal subluxation 6 clock hour with anger recession 1 clock hour. Initially, IP was at 26 millimeter Hg. So my video is running or not?
No.
Yeah. Now it is running.
So this is the traumatic cataract, and as I told initially, so I make a 2 side port initially, and then main port with the help of the side port knife, and then main port with the 2.8 incision, and put the visco. The capsule access is done with the help of the cystitome, initiated with the cystitome and completed with the Atrata forceps. It is about the 5.5 mm, and then try to actually capsule slightly become slightly elevated, and then we saw the vitreous slightly prolapse. So I cut the vitreous and then make a side pocket for the suturing eyelet of the Shioni ring, and then I make a 3 capsular hook to stabilize the bag in the area of the zonodialysis. So initially then job becomes slightly easier, and then rotate the nucleus and divide the nucleus by the stop and chop technique. And then one by one, I actually emulsify the piece. After the emulsification and removal of the cortex is done, so I just saw the vitreous also prolapse. So I just lose the this iris hook. So suddenly the capsule is shifted opposite side. So cut the vitreous again, and then put the visco, and then try to put the Sioni ring in this case. Slightly enlarge the side port, and then Sioni ring in that. And then I saw the Sioni ring is go into the vitreous cavity. So this is the disaster is done. So I think, and then cut the vitreous again, and then just again actually try it. So the Sioni ring I tried 4 times, but I unable to put in the bag. So I always actually I saw. So I actually decided to put the another Sioni ring, another standard CTR in the bag. So actually, when I dialing the another CTR, and then keep the trailing end of the standard CTR in the at the side port, and then try to remove the Sioni ring from the vitreous cavity. And then after that, I actually very unable to come out the Sioni ring and retrieve this Sioni ring. And then, but I try again, done. So, and then after that, we actually just engage the leading trailing end, and then comes out the Sioni ring again, and do the vitrectomy again. Then trailing end of the standard second CTR is implanted, and then again Sioni ring implanted. So this time is good, very good. But the picture abhi baki hai, because there the one disaster again is actually happened. The suture was broken actually. So by this reason, then I sought how can manage this case. Then I actually try to take the another suture and try to pass from this leading the anterior eyelet from the Sioni ring, and thus just pass it through this anterior eyelets, and with the help of the another 26 gauge needle, and then suture it with the sclera. And the 2 ends of the suture is actually pass out from this scleral pocket and suture it. So I actually in this time I feel this is the bag is inflated well, and then the suture is tight with the 5 to 6 knot, and then I implant the IL in the bag. And then the main port is actually this is the scleral pocket also suture because slightly elevated, and then the first post-operative very good, and after 1 month he get the vision is 6.6. I don't know how can, because the patient was actually young, so it get the good vision. So thank you so much, ma'am. Actually, I presenting this video because my management may be slightly wrong, but you are all are the experts, so you can give the better opinion to how to manage the case in the better way. Thank you, ma'am, and Mohan sir.
Very challenging video, and I knowing you and having watched your different surgeries, I know you can bail yourself out of any situation, Rakesh. But just a thought I want to ask Dr. Rohit. Could he have left his capsular hooks in place? The point when he removed the capsular hook, there was vitreous already there. I think it came forward and increased the area of dialysis. Could he have kept the capsular hook in place till he placed his CTR? Or
yeah, I think it was all is well that ends well, and the video shows his class.
Yes.
Despite all the challenges, he was able to get through to the finishing line.
Yes.
I would have done it slightly differently right from the start. My site of incision would not have been where the dialysis is.
Yes.
I would have been away. The initiation of rexes also would not have been there. It would have been right across. Because when you are initiating in the area closest to the area of zonular dehiscence, that puts more stress on the zonules. To be on the safer side, you should be farthest away, and the initiation should be towards the area of dehiscence, not away from it. That puts more stress. And the capsular axis should have been centered like that. And capsular hooks, definitely you used you did vitrectomy at the right time because the vitreous, that was further exaggerated by making the incision there. And, with the change in the dynamics, the vitreous was coming out. So triamcinolone could have been used by, having incisions at a different place. While inserting the CTR insertion in whenever there is a zonular dehiscence more than 90 degree, the insertion of the CTR has to be such that it should start from the area of intact zonules and then move on to the area of zonular dehiscence. You can do anyway if the zonular dehiscence is less than 90 degree. Here, since it was more, you could have gone, it was going, the direction was anti-clockwise. You could have made it clockwise so that it should have gone from the area where the zonules were intact and putting less stress. And I would not have removed the capsular hooks. I would have put in the CTR slightly, before, because the biggest saying is that it should not be later than what it should be. So before the last nuclear fragments were about to be taken out, I would have, implanted the CTR and provided a horizontal support in addition to the vertical anterior-posterior support, which was being provided by the capsular hooks. But how you managed when you broke the suture and how you went in, hats off to you.
Yes.
Thank you. Thank
And
you. Thank you,
could you have thought of placing a CTS instead of a CONE ring altogether, a CTR and a CTS?
Absolutely, absolutely, absolutely.
Yes, ma'am. Actually, initially, I planned to initially we put the CTR first and then actually followed by the CT segment. So this will be maybe the better way. But in this case, actually, we have the CONE ring at that time. So I put the CONE ring first, and then actually when I see the vitreous is prolapsing more, then I put the CTR.
I think no, the main thing is not to make the incision at the area of the dialysis, because you're going to the phaco probe, you are hydrating the vitreous there. Yeah. So more vitreous would come.
Can I add one thing, Chitra?
Yes.
I think the incision should be aware. Rohit said very nicely.
Yes.
First thing is, when you have a subluxated cataract, as soon as I put the incision, I put viscoat in the area of the subluxation. Then I put tricot. Always remove the vitreous first there. Okay, you can go past plana, you can go limbal, whatever you're comfortable. This is the ideal indication for past plana. Go through the past plana, have the anterior chamber maintainer, and then you can go through the past plana, remove the vitreous which is prolapsing out, because the tricot will be able to delineate the vitreous. And then put the capsular hooks. Then you proceed. Because every time you have vitreous there, this problem is going to come. So take care of the vitreous first, put the capsular hooks, and then, do the rexis, put the capsular hooks, and then go ahead with the surgery. All other things he has done so well. Hats off to you, Rakesh.
Yes. Thank you, sir.
Dr. Ramurthy, I think everything has been covered. You have to add.
Just very well managed. I mean, hats off. He was in a very difficult situation. He came out of it so well. But today, with the availability of IMS segment, as others pointed out, the combination of an endocapsular ring with the IMS segment would be the way to go. The CTR is always, the Sionis ring is always a little more difficult to maneuver. So yours is a traumatic cataract, and this was not, though the large subluxation. The endocapsular ring initially would have provided enough circumferential support. You could have completed the surgery. Then subsequently, you could have slipped in just before implantation of the intraocular lens, you could have slipped in a CTS, which can be done in a more controlled manner to fix the capsular bag onto the sclera. But otherwise, I think all points have been already covered. The only other thought is that, nowadays, the more and more we are believing that putting in a 3-piece lens in the sulcus and creating an optic capture in these subluxated lens further stabilizes the bag, and apart from the devices that you have already put in.
Yeah. And of course, the final thing is you could have done remove the cataract and placed an iris clip and got away without doing any of these things. So we shall go on to our next speaker. Anyway, hats off to you, Dr. Rakesh.
Thank you. Thank you,
our next surgeon is also showing a very interesting video. Dr. Sunil Ganekal, who's a chairman.
Dr. Sunil called up. He may not be able to join right now. Some connectivity issue. He'll try to join a little later. He's in a poor network area.
Okay, you keep a watch. If he's joining, then I'll do it. Yeah. So we shall now go on to our next young dynamic surgeon, Dr. Vineet Joshi, who is a consultant ophthalmologist specialized in cornea and anterior segment and cataract from LV Prasad, Hyderabad. So on to you, Dr. Vineet. Let's see your interesting case examples.
Thank you, Dr. Chitra. Thank you for giving me this opportunity. Thank you, AIOS, ARC, and a very good afternoon to our expert panels. Is my video screen seen right now?
Yeah.
Okay, so just to add to the points which were discussed earlier about IOL opacification, the great points put forth by Dr. Om Prakash, Dr. Rajan, and I think I'm just going to show you a similar case where I did what you were suggesting. And so this was a case 4 years back. We had an IOL opacification, again a hydrophilic lens. Now you can see here, this was exactly what Dr. Rajan was saying, that the optics is separated from the back, but the haptics are fused densely. And I was trying to get around it, but if you see, I was trying to pull it out, it was tenting the bag and it would have come out in toto, which I didn't want to do in this case. As the patient had a vision of 2120 improving to 2080, I thought if we could do it in a more atraumatic way and preserve the bag and put just an IOL, we can do it. So I went ahead with the IOL cutting Caesar and tried to separate the haptics from the optic. The problem was to dissect it from the upper side because the angle was a bit difficult from the superior incision, but still with the help of Sinski with an using it as an anchor or leverage, I kind of elevated it and then got a plane to dissect it fully and then put visco under it. So then it started to float in a plane which is comfortable to operate. Once that was done, then I took a micro forceps from the other side port to kind of bring it, level it out, and then get an way to cut to this proximal end. After this was done, I floated the whole optic into the anterior segment. It was quite large, so had to divide it diagonally so that the two pieces can come out through the clear corneal incision without extending it. So that was possible. And after doing that, you can see there was still a little remnant of that optic there, which also then it was easy to chip it off with the Caesar. Some part I tried to do it with micro Caesar, but I would tell you to avoid this because it flips, as you can see here. So Caesar is the best. Then I took a 3-piece IOL, and this time I put the haptics in the opposite diagonal quadrant so that they don't overlap the previous haptics of the lens. And the lens fit well in the sulcus without any issue. So that went well. And the patient did well. At 1 week, vision improved to 20/20. And she was happy with the quality of vision. So that was one. I was just going to share three videos which I operated in the last few months. And I thought I'll just get all of these in a short sequence. The next is doing cataract surgery in a very hazy cornea where we had planned to do DSEC as well. What I wanted to highlight here is how quickly the cornea becomes so hazy, especially when you're doing it in a case where there is already a existing PBK. Now you can see the central area which is hazy here, and when you remove the epithelium, it bleeds, and after some point of time, it starts to become hazy from both the sides, from the epithelial side and the endothelial side as well. So what I felt here is after doing trench, I couldn't see anything at all. And the last thing that you want in such cases is the rent, because that will complicate all the scenarios that will come forward. So the best thing what I felt was to just prolapse the nucleus in the anterior chamber, because anyways you're going to do a DSEC. So break it into pieces and get it out here. What really helped here was doing hydrodelineation, because that golden ring which shines, that gives you the contrast that yes, somewhere you can see the nucleus and you're eating it and not anything else. So my heart was pounding at this particular step, because nothing was clear until the cortex was aspirated fully and I could see a red glow. But you can see the amount of whiteness and the haziness in the cornea, which increased. If you just see a few minutes back, it was not that much. So it is very tricky. And at all costs, try and avoid, like I tried to avoid a PC rent, and luckily it was successful, and I proceeded with desmetorexis and DSEC after that, and it went well. The last case is in a traumatic case, post-corneal tear repair, small tear with 3 sutures only. We removed that 1 suture, but what happened was he developed a traumatic cataract. Ideally, in traumatic cataracts, we just aspirate loose lens matter at the first visit and don't touch the back. But in this case, I think the lens matter was so loose that it had to be aspirated fully. What it led to is that the anterior capsule had a rip and it was fused with the posterior capsule. Now, this was a unique challenge. So I had to separate the anterior capsule from the posterior capsule and make a customized rhexis with a forceps. So half on one side and half on the other side. But at 6 o'clock, you can see here, there was a kind of, we can't say it is a posterior synechiae, but it was a fibrosed anterior capsule. So I just divided it with cystitome and made some space to kind of convert it into a half rhexis on one side and avoid touching in that fibrous region, because that's where it would have gone to PCR. Luckily for this patient, that it did not involve the posterior capsule at any point of time, and we could get two half rhexis in place. And so what I could do is I could place the IOL horizontally in this patient, which was stable, and the patient did pretty well. And luckily for him, the scar of the tear was not in the visual axis, so he was seeing 20/25 by 1 week. So that was it. Thank you.
Very terrific videos, Dr. Vineet, one to beat the other, and a lot of very relevant take-home pearls in this. I mean, there is, you have told us everything about the IOL opacification, and this was very well discussed, so I'm not going to go into the challenges of that. But what I would want to ask you here is, when would you think of doing a sequential surgery or a combined surgery with a cornea and a cataract surgery is concerned?
Sequential surgery in doing in EK triple is a bit challenging, because especially you will have to wait for a long period of time. Now, if you're already seeing that if the cataract has developed, might as well buy the time for the graft to survive, because doing a second surgery is again going to cause endothelial cell loss later on. But sequential surgery you can do in some cases of DMEC in Fuchs endothelial cell dystrophy, where the cataract changes have not started as much. And it is well documented that if the natural lens is still doing fine, the visual outcomes are much superior. Like the visual recovery is very fast for those patients. So yes, mostly I would err on the side of triple procedure if possible. But in such challenging cases, very difficult to do. Whenever the cornea becomes hazy, I think maybe I could have used an endo illuminator or something, but in that point of time, I was a bit anxious.
Yes, endo illuminator could have been used. My only concern is situations wherein if the cataract is not as it was, you know, IOL power calculations become a challenge in some of these eyes. So if you are do it in a sequential manner, maybe it could have helped. But each of your cases were beautifully dealt. I want any of the expert panel to participate and ask question. Dr. Kapil Vora, would you want to add something here?
For the first case, you know, which we did, it was perfectly done. I would have used an AC maintainer, you know, to give support, to have an inflated big bag all the time. Because, you know, with the amount of manipulations being done, you being a cornea person would have been wary of, you know, corneal endothelial trauma. So I would have used, you know, an AC maintainer along with to, you know, give further protection to the corneal endothelium.
Yeah, that's a wonderful thought. And of course, endo illuminator probably, but you did it very well, superbly well.
Very nice videos.
Can I say something, Chitra?
Yes, yes.
Okay, as far as the first case is concerned, see, the second case is beyond my capabilities. I won't comment on that.
Yeah.
As far as the first case is concerned, we have a series of our own, because as Dr. Mohan Rajan said, there was a particular kind of IOL which used to turn opaque after 2 to 3 years. And it is actually very difficult to separate out the haptics if they are Rayner type. And if you have the 4-point haptics, it's slightly easier to separate them out and you can get an intact bag. But most of the times when we got these cases, already a good big posterior capsulotomy had been done by the surgeon. So the problem arises from there. although this capsular rhexis is also fibrosed by the time the patient comes to you, but most of the times when you're trying to pull out the haptic, this spreads and you don't have any bag left. So what we have done now is that, yes, we do try to separate it out if there's a capsulotomy, but if it is, badly fused, like in your case, we pull out the whole bag, do an anterior vitrectomy, and now we have very good methods of scleral fixations, and we resort to that. This is what I would like.
Yes, yes. There are different ways by which you.
One point I would like to add, Chitra. We need very nice videos. Only thing is, while cutting the optic junction, the first case, the opacified,
yes,
I would always hold the optic because I need to have some grip there, some sort of resistance. I hold the haptic with the micro, that is a lens holding forceps. Okay, hold the haptic so that you will now have better grip while cutting because you will not without giving traction on the bag. That is also very important to cut. So you want to make sure that there's no traction on the bag as well.
Yes.
Yes.
Thank you very much, Dr.
Very nice.
Very important
wonderful
points,
videos. You do stay on with us and add your comments along the way. So we shall go on to our next speaker, Dr. Anish Madhavan, who's a
Ma'am, Dr. Sunil has joined back. Can we?
Oh, yes. Sure. He had messaged. We would start off with Dr. Sunil Ganekal, who's the chairman and medical director of the Davangere Nethralaya Super Specialty Eye Hospital at Karnataka. And he's going to be showing us another case of a dialysis and how interestingly he managed it differently. On to you, Dr. Sunil.
Good afternoon, ma'am. Hope I am audible.
Yes.
Okay, let me give a brief introduction about the case. This is a 52-year-old gentleman who had a gross subluxation of cataract lens. Almost 8 clock hours of subluxation was there. So let me show you some modified technique which I used to manage this case. The paracentesis was done. The gentle capsular rhexis was done without causing much zonular disturbance. Make sure that you should be very gentle enough to cause much more zonular increase in zonular dehiscence. So completed with the capsular rhexis forceps. Once you're done, the capsular hooks are placed in the area of zonular dehiscence. 2 capsular hooks were placed, one on either side, and gentle hydro procedures were done. And the phaco was continued and the chop was done. Relatively a soft cataract. Once you're done, the CTR was inserted to further stabilize the capsular bag. Then the cortical aspiration was continued and all the cortex was aspirated. Viscoelastic was injected to into the capsular bag. It is a 50 proline suture, polypropylene suture, passed through the clear corneal wound and got out through the 1.5 millimeter from the limbus. You can see here the tip has been modified at bent at 2 millimeters from the tip to create a capsular hook. And you take an intrascleral bite of this 50 proline suture. Once you're done, using an end grasping forceps, bring it into the capsular rim and engage the capsular rim. And you can pull this 50 proline thread to stabilize the capsular bag. The second suture was passed and guided through a 30 gauge needle and brought it out 1.5 to 2 millimeters from the limbus. Pull the suture, pass it intrasclerally. Engage with the end grasping forceps and bring it into the capsular rim and pull it gently as much as required to stabilize the capsular bag. Once you are done that, we have a 3-piece multi-piece IOL was planned and it was placed in the bag. IOL was well dialed into and its centration was done. The viscoelastic was removed from the antechamber and as well as from behind the IOL. The ports were hydrated. Then triamcinolone was injected with the antechamber maintainer to check for the additional any vitreous which has been left over in the antechamber. Limited vitrectomy was done in the zonular dehiscence area. You can see the well-centered IOL. Now the scleral suture, the polypropylene suture is cut in flush with the sclera. So it is buried within the sclera without any exposure. Similarly, it was cut on the other side. So you can see a well-centered IOL. This is one of the modified techniques one can follow in subluxated cataracts, subluxated IOLs. Even for the iridodialysis repair, this 5-0 polypropylene suture is a very useful technique in management of these complicated cases. Thank you.
Very challenging case and very well done, Dr. Sunil. It's just that as we were discussing the earlier cases, which you must have watched, maybe making an incision at the site of the dialysis could have been avoided. And my other thought was, you know, like, how do you manage the tension of the sutures so that, you know, you have not even cauterized the cut end of the suture finally, so that you make it little bulbous so that it gets stuck in that place.
No,
the suture could have got loosened up a bit and the IOL might not have been so centered, no?
The intrascleral course is too long, madam. So that's the reason why you need not cauterize the tip. If it has been a short intrascleral course, probably you need to cauterize to prevent the slippage of the suture.
Yes. So on to the expert panel. Dr. Rohit, do you have anything to add here?
It was a very good innovation. I had not seen it before. And so hats off to him, how he has managed.
Yes.
Basic points remain the same in managing, and how you fix and how you fix the back to the sclera is something where everybody has his or her own choice of doing things.
Yes.
We have Susan Jacob, who has her own clip technique, and all these techniques have come up. But I still stick to the CTR and a Sione ring for that.
Or a CTS for that matter.
CTS.
Yes.
CTS, not a Sione.
For that.
Yes. Dr. Ramurthy, would you want to add anything here?
Very, very nice video. I mean, very
Yes.
nicely managed.
Yes.
Something different from what we have all used to.
Yes.
And as Rohit pointed out, there are various ways of managing the capsular bag, and this is one of the ways. I just used a slight variant of this for doing scleral fixation of intraocular lenses with an eyelet, where we have used a 5-0 proline suture, created a bulb both on the inside and the outside, and just fix the lens onto the sclera. I mean, I most often use an iris clip lens when I have to do a secondary implantation. This I found to be a very interesting technique where, you know, hardly any much dissection had to be done. Just pass the suture on either side of the conventional eyelet of the scleral fixation lens and fix it. This was something different, a similar concept used for fixating the bag. I mean, something worth trying.
Yeah. Really amazing. Nice surgery.
Very innovative.
Very
Thank
innovative.
you.
So we
Your point, I mean, both from the previous video and this is that, I mean, I think we should avoid making the initial incision at the point of subluxation.
Yeah,
I mean,
true.
Yeah,
I agree.
surgery is so much more easier.
yeah.
Agree.
The vitreous will not come out so much. So we shall now go on to our next speaker, Dr. Anish Madhav, who's Madhavan, who's a specialist in cornea and cataract surgery from Dr. Anish Madhavan's Eye Hospital at Kollam. And he has another very interesting case to show us. Lot more discussions there. On to you, Dr. Anish.
Thank you, ma'am. And thank you, ARC and Chitra madam, for giving me this opportunity. So I'll just share my video. It was an intumescent mature cataract.
Your video has to show. Just 1 minute. Your video is not playing.
You have shared the wrong screen, sir.
Maybe
You have to click on stop sharing, then you have to share the right screen, sir. The video screen. Better you share the entire desktop, and the desktop is showing us. Or you can switch the.
Okay. Stop sharing, and then I have to go share.
Open the video once, then start sharing. Click the video, the window, and if it has got audio, share sound. Yes, sir. I think it will work. It may work. You're getting white right now.
No. Now it is.
Shall I share?
Now it's getting. Yeah, you can share. You can share.
Need of Chitra, shall I share?
yeah, you share.
Yeah.
Just a second.
So good afternoon, everyone. This is an Intumescent mature cataract. I'm just, as usual, I'm just poking the anterior capsule and decompressing it to reduce the intracapsular pressure. And the capsular pressure was being reduced, and I'm proceeding with a capsular rhexis with 26 gauge needle, and the rhexis was coming nicely. But many a time, you know, the mid-peripheral area will be little raised, or there will be a hump like. So if the rhexis goes onto that hump, that mid-peripheral hump, the chances of a rhexis runover is more because it can extend to the periphery. So it is always better to keep it within that hump. But unfortunately, it went onto the hump, and you can see at that point of area, it went for a rhexis runover because the rhexis has gone on to the that hill area and then it went down. You can prevent it actually. If you want to prevent it, I think after decompressing, you have to just sweep the anterior surface of the lens with a dialer or make it flatter so that there won't be any hump. And here I am going for the chop. I am doing a vertical chop here, and you can see it's a little hard cataract, so I have to separate the pieces nicely to get a nice split because there will be leathery fibers will be there, so you have to make sure that these quadrants are being separated nicely. Here I'm trying to emulsify the pieces a bit in the anterior chamber itself so that I don't give much stress on the posterior capsule to prevent that rhexis runover giveaway into a posterior rent. So, but unfortunately here you can see there is a sudden surge happened, and immediately you see there is a rent. The posterior capsular rent has happened. You can see a very large rent. But luckily the piece was in the anterior chamber, so I tried to keep the piece in the anterior chamber itself, and with the help of the viscot I plugged the rent area and tried to emulsify the piece, and I made sure that the piece should always be in the tip. I never allowed the pieces to move away from the tip. So I just made a small chop and try to emulsify it. I didn't make big pieces. If I make two separate pieces, definitely the chances of drop is more. So I try to emulsify the whole piece as such, but I never allowed the piece to move away from my tip. My phaco power was less, but my vacuum was high. So now I remove all the pieces. Luckily the vitreous was not disturbed. So with the help of viscot, the vitreous was nicely pushed down, and I just cleared the cortex. You can see that trend nicely, and then I placed a 3-piece IOL in the sulcus, and I try to keep the haptic away from the rhexis runover area, and it was kept in the sulcus, and the case was finished. Thank you.
Thank you very much, Dr. Anish. A lot of pearls came out of this presentation. It is just that I would have preferred to, if a small rhexis had been created and then you had increased it later on to avoid that extension, because the rhexis was started off a little large, that happened, and the decompression is sometimes not adequate, even though we think we have adequately done it. And of course, these are the ideal cases for doing an IOL scaffold too. You managed it very well. The way you did a bit of an anterior chamber phaco so that area of extension does not go further, wrap around, and you did it very well. You managed it very well. But in any other hand, there could be a possibility of those fragments going in through that area. The PCR was already there, no? So you could have slipped in and a 3-piece IOL, and then gone ahead and removed the fragment and done a vitrectomy, and then was ensured that the haptics were placed away from the area of weakness. Dr. Mohan, you have anything to add here?
No, I would have done, I think it is beautiful video, very well managed by Anish,
Yes.
but I would have done certain things differently. One is when I have a hypermature intumescent cataract, I always do the rexis with the Utrata forceps. Either a micro rexis forceps, I would not do with the needle because you will have less control with the needle and you will not be able to control it. And that's what has happened, number one. Number two is when you lost the rexis, immediately what you should have done is you should have tried this little rescue technique wherein you flatten the capsule and pull it in the same direction. If you pull it in the same direction, then probably you could have retrieved the rexis and prevented the loss. Third thing is I would have chopped and made the chop smaller into this thing because what you try to do is you try to chop and try to bring that entire nucleus up. Yes, I would definitely do an iris plane or antechamber pico, but I would have chopped it in the bag and then brought it up. Okay, what you did was the other way around. You chopped it, but you brought the entire nucleus up. So what happened was there was a traction on the weak area which extended back. Okay, once this thing is there, then always I put tricot to find out whether vitreous is there. Or even at the end of the surgery, I think you should have used tricot to find out whether vitreous. Even the people who small, the round and the thing, you didn't see any vitreous. But I would have put tricot there and IOL scaffold also. You can do that, provided you take care of the vitreous first. Take care of the vitreous, put an IOL scaffold, and then take care of the nucleus.
No, you could place an IOL scaffold, take care of the nuclear fragment, and do vitrectomy in front of the IOL, and then go back behind the IOL and do a vitrectomy too.
And also bimanual IA. Once you see a PCR, no coaxial, bimanual. Separate the irrigation from the aspiration.
Yes. And Dr. Rohit, do you have anything to tell about the direction of chopping in the case of a rexis tear?
Yeah, it has to be in the direction, not away from it, not 90 degree from it, because that would put more stress on the make the tear go and become a wraparound tear. And when he was trying to bring those things forward, they were not separated, as Dr. Mohan said. Since they were not fully separated, and in trying to doing the maneuver in the plane in which the nuclear pieces were, those were putting more stress and made the tear a wraparound tear. IOL scaffold is definitely the answer. Another great thing which I have been doing lately, which I've realized is a big help, is a low IOP phaco. And I'm using around 28 millimeters of mercury at 20. And even if you have a posterior capsular rent, the nucleus doesn't fall behind. That is another beauty which I have realized. I've seen at times, when you just try it, everybody should try it. You just try to raise the bottle height and see how much fluid is going in. When you reduce the bottle height, the amount of fluid which is coming out of the phaco handpiece is very little. So when you are doing a low IOP phaco, even if it is extended and you're not sure whether it is pre-equatorial or post-equatorial, you cannot undermine the importance or belittle the importance of low IOP phaco. So low IOP phaco is something which should be adopted as a prerequisite when you are in such a situation.
Yes, and should the lateral separation of the fragments be avoided in the presence of a tear?
It should not be much. The lateral separational forces should be minimal. Either be out or be in, and the flap motility sign, the flaps were motile till some point. And suddenly when you were doing it, they stopped being motile, and that was the end point of safe phacoemulsification, and you should have converted. That is another point. But in very hard cataracts, if you can, you should try to bring it forward. You can do all these, use the flap motility sign, when the nuclear fragments are maybe till grade 3 or so. With grade 4, grade 5, with so much of increased anterior-posterior diameter, you have to be wary of, that the flap motility sign will eventually become a post-equatorial wraparound here. So hard nuclear fragment, if it is there in such a situation, if you can do it supracapsular or convert. Dr. Mohan, would you like to add something to it?
Yeah, absolutely. I think I fully agree with you because the flap motility sign is something which is very important. See, for him, the tear was on the right side. my entire manipulation would have been on the left. Completely on the left, never on the right, never near the tear, always on the left. So it makes your life easy because we are all right-handed surgeons. We are all used to the chopping on the left side. So left side, you brought the thing to the left. Make sure there's complete separation before they brought the nucleus up. That's I think, yeah.
The site of incision is also very important. It should not be in the in the plane of the extension. If possible, if you can have it at some angle, that also helps. Because if it is in the plane, the site of incision and the rexus tear, if they are parallel to each other, that predisposes more to a flap becoming, the anterior capsular tear becoming a wraparound tear.
Dr. Ramurthy, you want to add anything? Dr. Kapil, before we go on?
Most points have been covered, but just to prevent the problem which happened, of course, all of us know it. He very nicely described the hump where the rexus tends to run off. Sometimes even when you're proceeding with half the rexus, you find there is an area of cortex which is bulging forward. Even at that step, you can go ahead and aspirate a certain amount of cortex over there, or introduce a certain high viscosity viscoelastic, something heal on in that place just to flatten it out so that the rexus is very often what happens is it's going quite smoothly. We have covered 270 degrees. You get very confident. You think it's almost going to finish off. And then that's the time when you have a runoff. So you have to be cognizant of the fact that rexus runoff can happen at any time. And especially though Mohan mentioned it, I do all these cases with a bent needle only. And it works quite well with me because whenever I go in with the Utrata needle, Utrata forceps, I find that there is a tendency for the AC to shallow.
Yes.
Whatever be your preferred instrument, it's a good idea to keep the anterior capsule flat right through the stages. And as was mentioned, in these cases, phaco chop is a good idea, but I would have gone ahead and split the nucleus into two. And with the separation happening away from the area where the rexus runoff was there, and subsequently brought each of the fragments into the anterior chamber, and with using adequate dispersive viscoelastic, gone ahead and done a gentle phacoemulsification. And I think this is an ideal situation for doing an IOS scaffold where the anterior vitreous phase is still intact and there's just a couple of nucleus fragments. And you have a rexus, enough rexus to support the three-piece lens also. And you nicely tamponaded the anterior vitreous phase with a dispersive viscoelastic. And then you could have gone ahead and managed this case. But well, ultimately, whatever you did, it worked out very well in your hands. And that's what matters.
Brilliant. Yes.
You had pointed one point, which that you create a small rexus. That is a very important point, which you said. And after that, you should do what Chi Soon Paik does. He does the capsular milking. You know, when you do needle decompression in the center, the central area is concave, whereas the mid periphery is, is still has still lot of cortex in it. So you have to milk it towards the.
Yes.
So that is another point which should be.
Yes, yes. I'm very glad with the kind of videos which are saying, one, the surgeons are of great caliber, but also there is so much of discussion point which is coming forward. And I think it's not just you all of us are learning from each of these videos. And thanks a lot, Dr. Anish. We shall now go on to our next speaker, Dr. Ghulam Ali Kamdar, who's the director of the Kamdar Eye Hospital at Jodhpur. And he has another interesting situation to show. On to you, Dr. Ghulam Ali.
Good evening, ma'am. Am I audible?
Yes.
And my video is visible too?
Yes.
Yeah. Thank you, madam. Thank you for opportunity. And this is again, I think, the third case of journal dialysis. And I did same mistake as previous surgeons did. I made an incision at journal dialysis area. This is the case of the traumatic subluxated cataract with closed funnel retinal detachment. So we planned a phacoemulsification with the CTR and capsular hook. And VR surgery for the retinal detachment. We chose CTR because subluxation is only 3 to 4 o'clock hours, as shown in the video. And 2 side ports were made for the instrumentation and 1 small stab incision for the capsular hook. And 2.8 millimeter main port for the phaco And then we inject the trypan blue in the AC to stain the white cataract. And after staining, we started a capsular access, initiated with the 26 gauge needle cystatome. It started from opposite quadrant from jonular dialysis, slowly, very patiently, to avoid the stress on the jonular, weakened jonule, and it's beautifully completed. As in previous two presentation, both of them inserted the CTR after phacoemulsification, but I always insert the CTR before doing hydro or after hydro procedure. In this case, I put capsular hook first to stabilize the capsular bag to the equator, then put a viscoelastic again, and then preloaded CTR inserted slowly just under the anterior capsule. This is beautifully seen in the video, just below the anterior capsule. Very and after the insertion of this CTR, I did hydro procedures very gently and ensure good rotation of the nucleus. A patient is actually 45-year-old and the cataract was very soft, and phacoemulsification, I did phacoemulsification with direct chop method, and very I using the very low parameters to reduce the stress on the weakened jonules. The phacoemulsification completed uneventfully, and after that I clean up the whole cortex material, and then I hand over this surgery to our VR surgeon for vitreoretinal surgery. Thank you.
Thank you very much, Doctor. I just wanted to, it was a nice video to see. If you're, just a thought, if you're actually going to place a CTR a little later, would you want just one capsular hook and might have placed two capsular hooks? And of course, the incision location again, which you had already accepted, would have been in a different position. If you are placing a CTR earlier, maybe one capsular hook is fine. When you want to do it a little later, then if you have the bag nicely stretched with 2 or 3.
At that situation, we need more hooks, ma'am. But yes, I put only one hook because I planned earlier insertion of the CTR.
Yes. Now, the other question which I have is, supposing the amount of subluxation was actually more, I would want Ramurthy, Mohan or Rohit, anybody to tell me, how would you center your axis? You need to decenter it, but how do you exactly do it? On a flax, how you do it? How manually, how would you do it?
On a flax, it's easy to center it. You can actually center it very nicely with the flax. You can do the pupil centered on the thing which is on the flax. In the manual, it's very difficult. You can probably, sometimes you might have to do it only after the lens implantation. Probably you have to this thing, because invariably decentered.
Yes.
But what I would have done differently from what he did was, I would have put the CTR much later. The CTR much, not at the beginning of the surgery, because the CT, the capsular hooks are good enough for you to go ahead with the cataract. In case there was a posterior capsule rupture, which can also happen because subluxated cataract, then you are in double trouble, because you are having a CTR in the bag that has to be taken care of, and there'll be a problem. So the capsular hooks are good enough to have the support. At the end, you probably put the CT, the capsule I'm sorry, the CTR.
But again, if it is a traumatic cataract, maybe a CTR could have sufficed in the situation. But if it is a little likely to be a progressive kind of a situation like a pseudo exfoliation, then a CTR with a CTS would have been needed, not just a CTR alone. Dr. Rohit is itching to say something. You have to tell anything?
I think Dr. Mohan Rajan has aptly put forth the point about the timing of CTR.
Yes.
Once, if you put capsular hooks, then you can delay the putting in of the CTR.
Yes.
CTR, when to put first, when after putting capsular hooks. That is another thing which we have to be absolutely clear. If the nuclear fragment is hard, then you can delay it. Because when you are aspirating, the nuclear mass doesn't allow the capsular bag, the fornices of the capsular bag, to be aspirated by the fluidics, because that hard nuclear fragments prevents it. But if it is softer, then in between the capsular hooks, it tends to come with your fluidics. So if the if the nucleus is soft, then CTR can be put earlier on.
Yes.
But if it is hard, you can delay it, because putting it is also not without problems. As he has said, if there's a capsule rupture, you'll end up in a soup. So that is another important. And you can use nuclear scaffold also to your.
Yes, sir. Yeah, exactly. Dr. Kapil, you have anything to add?
I totally agree with Dr. Mohan Rajan and Dr. Rohit.
Yes.
An excellent surgery done, Dr. Kamdar.
Yes.
Congratulations.
Yes. Excellent surgery. Dr. Ramurthy, anything? Shall we go on to the next speaker?
Yeah, very nice surgery, Dr. Kamdar. And I think he manually beautifully decentered the rexus. That's what I noticed. Yeah. I mean, the way the positioning of his rexus was very apt. My only doubt is more regarding the principle involved. This was a patient who required a vitreoretinal surgery also. And he handed over the case to vitreoretinal surgeon. Whether this would have been a case for just removing the lens, doing the vitreoretinal surgery and doing a scleral fixation by our vitreoretinal colleagues. And how far we go as far as handling these subluxated lenses and trying to fix them onto the back is something that you keep wondering.
Yes, true. Makes sense. We shall now go on to our next speaker, Dr. Bharti Megur, who is a consultant in retina and uvea and also a proficient cataract surgeon from Megur Eye Care Center, Bidar. So she has another very meticulous surgery to show. So let's hear from her. On to you, Dr. Bharti.
Good evening, ma'am. Am I audible?
Yeah.
Thank you.
Had you opened your video before?
Yeah, it's opening. Yeah. Is it playing, ma'am?
No, it's not.
Not playing?
This is the right eye of 50.
No, it's not playing, not playing.
We can clearly see.
No, you stop that because we'll be losing out.
You stop your sharing, Dr.
Stop your
Bharti,
sharing.
then open your video, then start sharing. Stop share and then start share. Something else is being shared, which is getting a black window.
What about now?
No, we don't see your video. You stop sharing it now.
Sharing.
Stop sharing now.
Is scheduled for a toric lens implantation. I inject dispersive OVD.
No, Dr. Bharti, you have to stop that video now.
I'm careful in not pressurizing the anterior.
Is it not playing, ma'am?
No, the video is not seen at all. It's a dark screen.
Okay.
So that is why you stop sharing first.
Stop sharing. Okay.
Yes. And once you stop sharing, is your video seen? Dr. Anand, maybe you should help now. Maybe you could show her video and she could.
Shall I share the video, ma'am?
Yeah, you share the video.
Doctor. Just a second. Dr. Bharti, can you please stop sharing? I'll try to share at my end.
Okay.
Thank you.
This is the right eye of a 50-year-old gentleman. We can clearly see typical onion ring appearance of a posterior polar cataract. This patient is scheduled for a toric lens implantation. I inject dispersive OVD followed by the cohesive OVD. I am careful in not pressurizing the anterior chamber. I am aiming for a 5 mm central rhexis. Sizing and centration of the rhexis is quite critical in posterpolar cataracts, and understandably so, as we might need the anterior capsular support to capture the optic in the event of a PC tear. I am using low bottle height, low flow rate, low vacuum and power. The superficial cortex and epinucleus are removed with low parameters. Careful inside-out hydrodelineation is done. As expected, the nucleus is soft. A central trench is made. I am using the second instrument to tease out the lens material. It is coming in bits and pieces. The soft endonucleus is eventually consumed. Before removing the handpiece, OVD is injected into the anterior chamber to prevent it from shallowing as the phacoprobe is removed. We have a central bowl of epinucleus and cortex. Fishing it out of the capsular fornices can be challenging. I prefer to use viscodissection to separate out the epinucleus and cortex from the capsular bag. Using OVD, the epinucleus is displaced away from the capsular fornix and is gently aspirated out in a very slow and controlled manner. Using bimanual irrigation aspiration cannula, I remove the remaining cortex. The epinucleus and the cortex removal consumes much surgical time, as we need to be extra cautious and the chance of breaching the posterior capsule is quite high. All the while, parameters are kept low. OVD is injected each time before removing the irrigation cannula to prevent shallowing of anterior chamber. Maintaining the anterior chamber equilibrium is the golden rule to follow in these cases. This is probably the most important step which minimizes the occurrence of the PC tear in such vulnerable eyes. Slowly but safely, all the cortex is removed. Thankfully, all is well till now. However, there is a small central plaque sitting near the visual axis. It is not getting displaced with OVD. I try to nudge it with the dialer and posterior capsular tear happens. The anterior vitreous face is still intact and there is no vitreous disturbance. The tear is oval and at this point I am considering doing a primary posterior rhexis. After some deliberation, I went against the idea of a posterior capsule rhexis for two reasons. Firstly, the tear was oval and the risk of extension of the tear didn't seem likely. Second reason being the possibility of a breach in the anterior hyaloid face while doing a primary posterior capsule rhexis. I use cohesive OVD to form the anterior chamber and the bag. The toric lens is gently implanted into the bag. Most of the OVD is removed slowly and carefully. There is a possibility of little OVD left behind the lens. The IOL is dialed to the predetermined markings using the dialer and the irrigation. Side port hydration done. These are the post-op pictures. Patient is doing fine and the lens is well centered and the alignment is also good. To summarize, with this case it is quite demonstrative that by following the right strategies, one can minimize the chances of posterocapsular tear or anterior hyaloid rupture in eyes with posterior polar cataract. The principles of low flow, low pressure surgery along with maintained anterior chamber equilibrium will allow us to achieve the goal of minimizing the complications in such vulnerable eyes. Thank you.
Wonderful surgery, Dr. Bharti, and I think there was everything just exactly done, exactly the way it should be. But assuming that the situation was a little different, because that's how we have to go ahead with it, because you've done it all. If there had been a vertical split, which is possible to occur in these polar cataracts, and you had a toric IOL in your plan, so what could you have done, Dr. Bharti?
There are two options, ma'am. One is to abandon the idea of putting a toric IOL and take a multi-piece lens and do an optic capture. The second option is to do a posterior capsule optic capture with the toric lens with the haptics being anterior to the optic. So The optic will be behind the posterior capsule and the haptics are anterior, and the alignment can be placed according to the predetermined markings. I'm not so comfortable with the second.
Yes. No, that's the other option, the way to go ahead and do this. Anybody has anything to add, Dr. Ramurthy?
Oh, did you get a ASOCT done, Dr.? I mean, it was a beautiful surgery, wonderfully demonstrated, but did you have any idea about the intactness of the posterior capsule? Because what I noticed was even before the PC rent occurred, there was some lens matter in the anterior vitreous, which tells me there was an inherent defect over there. So in spite of the fact that there is a plaque over there, maybe especially since you're contemplating a toric intraocular lens, I would have not just left it as such, because most often when you try to peel it off, you end up with a rent. Thankfully for you, it just remained confined to that space. Most often, as Chitra was mentioning, it spreads in the from end to end. And one good thing is that the orientation of your tear was such that the haptics was at 90 degrees to that. So in these cases, even if there was a end-to-end tear, maybe you could have still placed the lens in the bag, even if an anterior vitrectomy had to be done. Otherwise, of course, that option of what you mentioned just now is also there, where you place the haptics in the bag and create an optic capture and stabilize the lens. But I feel if you had an ASOCT done, you might have realized that there is a defect in the posterior capsule, and peeling off that plaque would have ended in this situation, that you could have avoided that maneuver.
Exactly, sir. Actually, I could have planned for a AIOS capsulotomy later, instead of trying to venture out.
Quite thick.
Yeah.
These plaques have to be removed, you know. Can I add one thing, Chitra?
Yes.
It was really fantastic to see Deepak and Bharti's videos. Really, what a lovely video. I just want to know, see, one thing I would have done differently from what you have done, because there was a small oval tear on the posterior capsule, but it's not like a typical PPC tear like posterior polar. It's usually like two pillars, like what Chitra told. But this is a tear because you try to remove the plaque. Okay, now when you put a lens, I will not put the lens in the back straight away. So I will probably put the lens in the anterior chamber and then tuck it inside.
Exactly.
What I saw that you try to put the bag leading haptic into the bag and dial the trailing haptic. If you try to dial it itself, we can extend. Okay. So what I do is normally I use the good viscoelastic like Halon or even disco whisk, and then inflate the chamber very nicely, and then put the lens in front of the iris or in front of the anterior capsule. Then I use a Kuglen hook, then tuck the the leading haptic as well as the trailing haptic. I don't dial it inside. Once I know it is in the bag, then I slowly bring it into the portion, because being a toric lens, you have to bring it into the axis. So
actually, another important thing is, with the PCR there and you have placed a toric IOL, even viscoelastic removal becomes challenging. How to remove it from behind the IOL? So that is a challenge, yes.
I
might have done what Dr. Bharti did, because she did mention that, she used Halon, and that really pushes the posterior capsule quite behind and gives you enough space to maneuver. And as you could see, it was a very confined central opening. And good thing about this is that, as she also showed in the video, Halon will just flow out as one bolus. I mean, just she went behind the lens, and immediately I'm sure most of the material came out. If we had used a dispersive viscoelastic, that would have been more difficult to remove.
Yes. All wonderful points, well discussed. So, Dr. Kapil, shall we move on to the next? You have anything to add? Okay. So, we shall now go on to our next speaker. Now, there have been a small setback. Dr. Rajesh Joshi has not been well, and Dr. Satyajit was caught into very unfortunate problem which happened to Dr. Dr. Jaiswal, Arvind Jaiswal.
What happened?
Apparently, he fell off in the bathroom, and his brain hemorrhage he's had. So they are all waiting outside the theater.
When was it?
Just now, just some time back. So he couldn't. So Satyajit Sinha was not here to moderate along with me. So we are now going to move on to Dr. Ajay. I think our prayers are needed for him. We move on to Dr. Ajay Mehta, who's a director of the Kesubai Mehta Eye Hospital, Rajkot. And he's going to show us something, another very interesting video. I mean, hats off to all my speakers for bringing in so many variety of cases. So let's hear from you, Dr. Ajay.
Hats off to you, Chitra, for bringing all of them.
Yes, good evening, Chairman,
yes.
All the moderators,
yeah.
and dear doctors. Before I begin my presentation, I would like to thank Dr. Chitra for inviting me here and for bringing the AIOS to such great heights.
And our association goes to so many more years when you were so
yes,
young, no? Yeah.
Yes, Madam, you were my junior.
Yeah,
I was
I
learning
know.
FICO and then you were learning EC.
Yeah, I know.
But times change, you know. Right. So here is my presentation, and are you seeing the screen?
Yes.
Okay. This patient was referred by a colleague for a lens that had decentered on the first postoperative day. Actually, during the end of the surgery, the PC had given way while the lens was being dialed, as it is a toric lens. And then, because the anterior vitreous phase was intact, he had left the lens as such, and to his surprise, on the next day, he found that the lens was shifted to the nasal side. So now I've taken up the patient for surgery in an attempt to recenter the lens. The side ports open up easily, and the anterior chamber is thus formed with cohesive viscoelastic and local anesthetic. After that, I now try to make a bold attempt to recenter the lens with the help of a broad base spatula. So I gradually pull the lens towards the center, and by doing so, one of the haptics prolapses into the anterior chamber. But because the lens has centered and there is adequate support of posterior capsule in the periphery, I again put it back into the bag and try to finish the case. Do a vitrectomy of the anterior vitreous. All this while the lens is in its place, so I think the surgery is over. But as I remove the irrigation, I find out that the lens has now started again shifting towards the nasal side. So I form the anterior chamber with the viscoelastic again, and then from the lower port I introduce a side port spatula to do what is known as reverse optic capture. So here I slide the spatula underneath the lens and then gradually bring the lens, only the optical part, in front of the anterior capsular rim, and with a smooth maneuver I could achieve that. Now, because I had constricted the pupil, it has also captured the pupil. So in the next step, I am now going to introduce spatula from the superior side port, and then I will gradually release from one side, that is the inferior side. The pupillary capture is then released from the inferior side. Once this has been achieved, I then go towards the inferior port and release the superior capture, and the lens still remains in front of the anterior capsule while the optics are in the front, the haptics are in the capsular bag. In this way we are preventing any uveitis glaucoma ephema syndrome. With this we come to the end of the surgery, and this is the picture at the time of hydration. On the follow-up you can see that the lens is very snugly in its place and the capsular axis is in the square form. The toric IOL is horizontally placed as desired. Thank you for your kind attention.
Wonderful, Dr. Ajay, very gracefully shown, because this is a uniplanar design of these aspheric IOLs. So the challenges
Yes.
of a reverse optic capture you've shown beautifully well. But
Thank you.
supposing this had been a larger rexis, a little eccentric rexis, could you have done a reverse optic capture? Is one question to you.
No, so
Yeah.
now luckily only the day before I was discussing with a friend about what will you do when a toric IOL is put and the posterior capsule is ruptured. And so I had seen some articles about reverse optic capture, and I was so enthusiastic to take up this case, So I told my friend, don't worry, let me try. And the initial steps I tried without doing that capture. But then this step of putting the spatula behind, I read, and then I did carry out. And let me tell you, it's a very easy step. If the capsular axis is smaller than the optics.
It should be smaller than the optic. Any challenges in dialing the IOL to be in the same axis?
No, that's how the rupture happened,
Yes, I know.
The previous surgeon was trying to dial the lens to 180 degrees. He had put it at maybe 30 degrees, and so he was trying to rotate it. And at that time, he pulled the entire posterior capsule with it, it subluxated. So that's why with this single piece IOLs, we require much more dexterity and much more patience, at least at the end.
Would there be any change in your post-operative medications in spite of the fact that the haptic is there in the sulcus? Would you want to do anything differently, or would it be just the same?
No, because the haptics are the one which I had fault every time. The haptics are the one that cause the uveitis, glaucoma, IFIS syndrome. And that's why this technique has been devised. It is even published in the JSCRs.
Yes. Any experts, your opinion, all four of you, anything to add?
Can I add something?
Yes, yes.
I think it's a beautiful video, Ajay. Fantastic demonstration. The only thing is reverse optic capture in a single piece, especially also a toric lens, is not easy job. You made it look easy, but it's not easy. What I do normally is I do it both the edges of the optic. I bring it simultaneously up. I don't bring one side up and then other side will go back. So I do make two side ports on either side, and then introduce two spatulas, two second instruments. And once I know the haptic is in the back, and then bring the center of the optic up and capture it in this thing. So what happens is, that the entire optic will come up, because the regular optic capture is easier because it's the other way around. Okay, this is because you don't have angulation. It's a planar lens. So it's a planar lens, so difficult. So we make sure the optic is there, the haptic is there in the back, then bring both the optic, both the sides, that is the sides of the optic, up simultaneously, and then making sure that you have a good viscoelastic in the anterior chamber, cohesive viscoelastic, and then it makes life a little more easier, I feel, but still it's difficult.
Yes.
The rexis has to be small.
Small.
Yes, but I hope we don't face this situation very often, So.
Yeah.
No, but this is a video to be kept in mind for future use for any of us. Dr. Ramurthy, Dr. Kapil, Dr. Rohit, anything to add?
I think very nice video, Ajay. Difficult situation which you sorted out so nicely. I didn't, just a couple of comments in the sense that one is, I didn't see any digital markings over there. I suppose you had a digital overlay to guide you on the positioning of the lens?
No, it was not that, because this patient was sent by my friend, by my colleague. So we just had the desire to center the lens. But then
final positioning of the lens.
180.
Yes, 180.
Okay. Anyway, it worked in your hands. I would have ideally, whenever I'm doing a second time surgery on a intraocular lens or even a toric ICL, always have the marking or the digital overlay so that the exact positioning is there. Second thing is you did it so elegantly, but still in these situations with such a large PCR, at the end of the surgery, at least I would have put in some tramstone and state to make sure there's no vitreous strand. Sometimes you are surprised that there is something over there. And
no, I did the vitrectomy and the trams in along everything.
Tramstone was shown, right? Maybe
yes, it was vitreous was there, and I did a vitrectomy also.
Okay.
But because it is a 4 minutes video, I had to.
And the other comment I had was that, I have faced a similar situation. You could create a reverse optic capture because the where the haptics had to be located, the capsule was intact, and you could bring the edges of the optics up. I have had a situation where I did not have enough support by the posterior capsule in the area where the haptics were to be located. And because it was again a toric lens, I did not have a choice of rotating the lens in a different position. So basically what I did was to bring the haptics into the sulcus and create an conventional optic capture. I know the thick haptics of the single piece lens should not be left in the sulcus, and it does create problem. But I have shown it, and I have almost a 6-month follow-up of this patient, kept him on steroids for a longer period of time. Both his correction as well as his, the eye has been pretty quiet. So obviously this is not something we recommend, as was discussed. In these planar lenses, to create any kind of optic capture itself is a difficulty. But sometimes when you faced with these situations, you have to adapt to what you have, and it does work out.
There is a small thing that I would like to differ. Is reverse optic capture is usually done when there is a posterior capsule rent. So even if there is no support for the haptics, the optic fits so nicely in front of the anterior capsule that we did not then worry if the entire posterior capsule is absent. So there is no support required for the haptics. This is the optic which holds it lifetime. And as I showed in the postoperative pictures, even a routine toric IOL does not stay so well, and this style just fixed over there.
Rexis needs to be really small for that.
Yes.
Yeah.
Small enough, yes.
And to get the optic out of a small rexis, no, it's a very well done surgery.
I'm not sure about that, Ajay, because what Ramurthy is saying is there is a point, because if you lose the rexis in the axis of the toric lens, then lose the posterior capsule, you don't have support for the PC. How will the haptic stay there?
And if the if the AC gets shallowed post-operatively, this optic could go behind also.
Yes. The optic goes behind, then you have lost the lens.
No, I had a situation where while I was injecting the toric lens into the bag, the posterior capsule was damaged, and there was no support at all for the haptic to rest there. So I had to, it was a fairly high cylinder, I had a digital overlay. So basically I had no other option. It was a fine rexis, it was actually a LRCS case. And then I just brought the haptics up and created a conventional optic capture. I know that the haptics, a single piece of the haptic should not be left there.
No, that is we're not talking about that, Ramurthy. I'm talking about Ajay's contention.
No, that's what I'm saying. So I am not very sure that when you don't have capsular support in the area where you're leaving behind the haptics, at least at the initial period, maybe once it gets fibrous, there'll be enough support, but whether it will remain undisturbed right on the table.
Dr. Rohit, do you have anything to tell?
Somehow I don't buy the idea that if the posterior capsule is not there, you do a reverse optic capture. Because if it is not there, I somehow do not, I beg to disagree with Dr. Ajay for that matter, because, second point is that what Dr. Ramamurthy said, that he placed the haptics in the sulcus. For all the listeners, I would recommend, as he has also said, we should definitely not try to put the single piece haptics in the sulcus. Dr. Ramamurthy, you agree with me? It was a special case where you did.
Yes.
I had a
there's a toric lens inside. Yes.
Yeah, I had a lot of concern. Supposing I had a PC rent during phacoemulsification itself, I would not have injected a toric lens at all. This is a case where the lens had already been introduced. Patient had expectations. I thought, let me, instead of cutting the lens and bringing it out, let me see whether it works out. I'm not at all saying haptics can be left in the sulcus, thick haptics. But I did this, and at least in the limited follow-up I have of this patient, he seems to be doing all right.
You need to have a very close follow-up of.
Do you do a PI for these patients, Ramurthy?
No, I didn't.
Yeah.
So we shall now go on to our last speaker, Dr. Devyani Gadre, who's a consultant cornea and anterior segment from Gadre Eye Care Center, Rajkot. And we have lovely memories, Dr. Devyani, of our arduous trip to Rajkot.
Chitra, what a trip it was.
Pre-pandemic rush trip, yes.
Yeah.
Good evening.
Good evening, sir. Good evening.
We look at your video.
Yes. Thank you so much for the opportunity, ma'am. It's so nice to see you all. I'll share my screen now. I hope it's visible.
Ma'am, is there any audio in this? You're not getting any audio.
Devyani, we need to hear you.
I'm sorry. I was about to ask. Just give me 1 second. I'll stop.
If there is an audio in this, please stop sharing it. Then
Yes. Yes, I realize that. Just give me 1 second.
Sound also, please.
Okay.
Thank you.
Cataract
I hope it's audible
can
now.
be tricky at times. It's not always the cataract that troubles you. This is a case of a perforated fungal keratitis which underwent therapeutic keratoplasty with us about a year back. When we planned cataract surgery for this patient, we realized it was a non-dilating pupil with what appeared to be an anterior subcapsular cataract. Here we are trying to dissect all the pupillary membranes, and by the time we dissected half of the membrane, we realized that it was a single membrane which could be removed in toto if we found the correct plane for it. Once we found the plane, it was actually a tug of war between me and the membrane and its thick adhesions underneath the pupillary margin. Finally, we were actually able to pull it out in toto, and thankfully for us and the patient, the anterior lens capsule was not damaged in the process of doing so. Once we got it out, we were actually able to get really good dilatation with the help of iris hooks. Here I'm trying to make a tear for the next challenge that we had, which was the rhexis. I believe in hindsight that this was not the right area to create the tear from. As you can see here, I have lost the flap, and now because of differential staining of the anterior lens capsule, I am actually tugging at the intact capsular bit, and in the process can create a radial tear which can lead to additional complications. When I finally realized that, I retrieved my cystitome yet again and went in and created a fresh opening in the anterior capsule, this time at a better area, because I was then able to create a flap, and the tensile strength and thickness, elasticity of the anterior lens capsule at this area from 2 o'clock till 6 o'clock was of much better predictability, and I was able to get a good rhexis margin there. And as we all know, rhexis is essential for a good outcome in these complicated cases. By this time I had reached the fibrotic band, and the fibrotic band was simply not budging. So we had to go in with the Vanna scissor and snip it apart. There's a lot of parallax here because the Vanna scissor that I had at hand was not angled, and therefore created a little bit of a blind procedure. Here I'm trying to retrieve the rhexis which was threatening to run away. And now that I'm back on track, I am yet again encountering the other part of the fibrotic capsule. This time, learning from experience, we decided to go in with scissors from the VR surgeon's kit, and this helped us get a clean cut of the fibrotic band. Here on forward, it was simply joining the dots and completing the rexus. Rest of the cataract was uneventful and the patient did well post-operatively. Few things that I have learned from this case are that we should always prepare a plan, wash the visco well before staining the anterior capsule, keep other instruments ready, and always have your fingers crossed. Thank you.
Thank you very much, Devyani. That was a wonderfully skilled surgery which you showed and very impressive. More for the sake of discussion, we are going to be talking some now. Now, do you think, I'm all for an iris hook, and at the least opportunity, I would use an iris hook myself. But do you think in a post-Bouquet case, maybe if a ring would have been a better choice, or do you differ? Because of course you could fashion out your side ports away from the graft host junction and do an equally good job, I'm sure. But do you have, being a cornea person, would you have any things to answer about that, Dr. Devyani?
Yes, so I have a couple of points. One thing is I completely agree. A ring would probably be more ergonomic and would avoid that many extra incisions into the cornea. I was lucky because it was a really large graft. It was a limbus to limbus graft that I was dealing with. So essentially I was still in the graft. But the second point being that I personally feel whatever you're comfortable with, you should do it, especially in your most complicated cases. And so at this point, when I did the surgery, I was more comfortable with the iris hooks. And that is the only reason I decided to go for it.
Yeah.
And I was just lucky that it was a limbus to limbus graft.
How was your IOL power calculation done, the astigmatism part of it?
Yeah, so it was a fairly regular, again, because it was a large graft, it was a fairly regular central 3 millimeter zone, and we were actually able to get a decent keratometry. Because it was an anterior subcapsular cataract, we were not able to get it through our optical biometer, but with the A-scan biometry, we were able to get a fairly decent IOL power. And since it was a poor prognosis cataract surgery, honestly, I had already explained to the patient the requirement for possible refractive surprises at the end of the surgery.
This was a clear-cut case of a fibrotic capsule,
yes.
But I'm sure Bharti would be better able to tell about, how beautifully Dr. Deepak differentiates the fibrotic capsule and a subcapsular plaque, wherein it seems, yes, if there's a yes, Bharti, would you want to tell something on that?
Yeah, ma'am. Actually, there is always a certain plane at certain points where there are weak zones of attachments between the anterior capsule plaque and the anterior capsule. When you are able to assess the cleavage, that you can get a plane of dissection and remove it. That is one point. Second is using a vitrectomy cutter. Using a vitrectomy cutter with low cutting rate, you can easily get a decent rexus.
Yeah.
I think this was Dr. Bharti. I think this was a calcified subcapsular plaque.
Yes.
Rather than a fibrotic one.
Fibrotic, yeah.
Number one. And I think in these patients, we should try to create a smaller rexus within the plaque and then try to dissect it 360 degrees.
Yeah.
The calcified subcapsular plaque, its adhesions with the anterior capsules. Once that is dissected, you can take out the calcified subcapsular plaque out and then create a normal rexus.
Enlarge the rexus, yeah.
Then enlarge the rexus.
Have been the way
it was a very the width of the calcified plaque was not that extensive. So that is something which would have led us to create a very small rexus in the center, central to the adhesion of the calcified subcapsular plaque to the anterior capsule.
To make a rexus in the plaque area is very difficult.
Yeah.
Not easy. So what I would have done is go beyond the rexus, beyond the plaque, the plaque, and include the plaque in the rexus within the rexus area itself.
Dr. Mohan, what you have to
I would have used UPSs there.
No, what you have to realize is that the calcified subcapsular plaque has adhesions to the anterior capsule.
Oh. Yes.
They are usually not in the central area. They are in the paracentral or in the mid-peripheral area, not in the mid-peripheral, between paracentral and mid-peripheral. So you have to create a small rhexis right central to the adhesion of the calcified subcapsular plaque to the anterior capsule. Yes. If that adhesion is quite central, then you may go across. But if it is not right in the center, then you can create a small rhexis, use a flat spatula or by creating side port incisions, and then use the flat thin spatula to separate them. And once you are able to separate them 360 degrees, then it is. But usually you can create, if the calcified plaque is adherent in the not in the right in the center, maybe away from the 3.5 to 4 millimeters central area. Dr. Bharti, what is your take on it?
Whatever you said is correct, sir. Actually, the adhesions are there in the mid-peripheral area. But Absolutely. When you get a small central opening, there are certain weak areas of adhesions where you can get a cleavage and using a spatula, get the membrane out. So whenever the adhesions are released, decent rhexis is very much viable, possible. Yeah. Then second point I need to make is, if the capsule is totally fibrotic, a vitrectomy cutter is a better option.
Absolutely. Yes. Absolutely correct.
Yes. So if it's a totally fibrotic without that subcapsular component plaque to it, then doing a vitrectomy cutter would have been
less cutting rates. Yes.
Yes. What would be the cutting rate, Bharti?
We would keep around 1,500.
Okay.
Very nice video, Dr. Devyani. I think you seem to have inherited your dad's surgical skills as well as his calm demeanor. Congratulations.
Thank you. Thank you so much, sir. Thank you.
Very nicely done. Both Mohan as well as Rohit had very relevant points, but as I could make out in the video, this was a fibrotic plaque which was extending almost end to end. So either way, you could not have avoided you can't go beyond it, nor can you come within it. So obviously this was a pupil which was tied down, but this fibrotic capsules is one indication for me to use an LRCS platform, because even though you don't get a free floating rhexis in these cases, it creates a nice template. And then you are able to, as you said, connect the dots and get a fairly decent centered rhexis. Obviously, in that case, you could not have done it because the pupil was so small.
Very small, yes.
Extensive peripheral anterior posterior synechium.
You have done it in this.
But that just makes me wonder whether this would be one of the indications for a Zepto, where you open up the capsule, where you open up the, the pupil, and then subsequently apply that to create a rhexis.
So we did offer this option to the patient, that after putting the hooks, we could do a Zeptorhexis for him, but there was slight affordability issues, and these patients, I have seen all cornea patients are non-affording. So.
All glaucoma patients are non-affording. So
Rajkot has got the richest patients.
Yeah. I don't seem to be getting them. That is for sure.
Anyway, I'm coming there to Rajkot on 24th April.
Oh, wonderful, sir. Great to know. Welcome.
But I think even if you get a can opener capsulotomy in these cases with multiple tags and with the soft cataract that you had, you could have got away with it. I mean, sometimes, these fibrotic capsules, you did a great job, but it's extremely difficult to get a round rhexis. In these situations, I just go ahead and create multiple nicks all around so that there's no single area of weakness. Yeah. And again, you can go ahead and complete the surgery.
Dr. Vineet, would you have thought of doing anything in the post-op steroids, anything different you would think? How long would you use it, or would be just like a routine cataract surgery case?
All the fungal. Fungal.
Yeah,
that's why I asked.
But but the graft looked pretty clear and quiet. I mean, you can still start probably steroids slightly higher than what you start in routine cataract cases, and then probably step it down one or two steps, and then just maintain it at a higher dose. Because therapeutic grafts, first of all, what would be their inducible cell density at the time of cataract surgery, don't know. Plus, the grade of cataract was quite high. so much of pupil manipulation, pigment dispersion. So it's always good to, in such cases, like there is a chance of secondary endothelial decompensation. So steroids, you have to step up.
Yeah.
Anytime.
This patient was quite quiet. I was able to, as you've seen in the photograph, but I have had a couple of other cases, again, post-therapeutic keratoplasty cataracts, where you had to remove these membranes, and they do lead to greater AC inflammation. I've been lucky not to have endothelial decompensation, but that's just luck.
Do you do the endothelial?
Unfortunately, they are very hard.
Yeah. No, do you do a specular?
Yes, I do attempt it, but sometimes it's difficult to actually get a good capture, which is reliable.
How will a DSEC work in these cases in case the endothelium decompensates?
Yeah, so if we have a good keratometry, which is relatively decent in the sense that it's not too astigmatically bizarre, then a DSEC is a viable option for these patients, especially with these large grafts. It is possible, and good results have been seen. So I personally have had that is the next option for this patient's graft.
Did you use BSS plus in this case?
No, so I've gone ahead and done a standard BSS only. No BSS plus was used.
But logically, probably those are those finer points which can be looked at
yes,
more optimal.
I agree.
Yeah. So I think it's just that two of the presentations were not there. So I think we were able to have a much more extensive discussion. For that matter, I feel we discussed every case piecemeal, and there's a lot of take-home points for all of us. So I think I should conclude stating that it is the uniqueness of the expert panel and the kind of special set of speakers who put their life and soul and brought out such wonderful videos from their video album that made this webinar so unique and so different and so useful. In fact, I keep saying this sentence every time because that's how the kind of ARC webinars have been, and that these video bouquet just brings out the kind of talent. I'm not even sure when I take the name of those surgeons, some of them are so young and different, I'm not sure, but different presentations come across. So it's truly been a most learning period for me in my post as chairman ARC, and thanks to one and all of you. It's unfortunate that my co-moderator was not there, but I have my ARC there always backing me up. And my thanks are due to Mr. Kripal from AIOS team for all their support. My special thanks to Sai and Manjula who keep raiding your inboxes with all my ARC mails. I do hope it doesn't bother you. I hope you just understand it's just my efforts at getting education across to all of you. And my very special thanks to Anand Sethi, and thank you so much for spending your Sunday afternoon with us and making it so much easier for all our speakers and by meticulously sharing the videos. Thanks a lot, Dr. Anand. And finally, most importantly, special thanks to Entode for being superb sponsors and never a question asked. And all these years they have been consistently sponsoring all my programs. Of course, Sun Pharma takes care of the PG program in the last year. And finally, and most importantly, I think I owe my thanks to all the attendees who watched these ARC webinars. And believe me, it's those numbers which eggs me on to keep coming back to you every single month and every single week with more and more webinars. Thank you very much, one and all of you. Thank you.
Thank you.
Thank you.
Thanks a lot, madam. Thanks a lot.
Thank you, Rajan sir.
Thank you. Thanks a lot.
Thank you, Prakash sir.
Thanks, Chitra.
Thank you.
Thank you, Mohan. Thank you, Rohit. Thank you, Dr. Kapil.
Thank you, Chitra. Thanks a lot.
Enthusiasm motivates all of us.